Well, good morning, everybody. Welcome to the 2021 UAB NF Symposium. My name is Rini Moss. I'm a program director here in the Department of Genetics, and I'm the one that's been communicating with you prior to this event, and we're excited that everybody is able to be here. We have a wonderful lineup of presenters today, as well as our Children's Tumor Foundation 2021 NF Ambassador, Ms. Lilly Brooks. So before we get started, just a couple of housekeeping tips. There is a Q&A option if you look in the panel below where you're seeing the screen right now. Please utilize that Q&A to ask questions of the presenters throughout the day. We have a panel of questions at the end of the day. If we're not able to answer your questions during the presenter's presentation, I'll save those and be sure to moderate and answer those for you all and present those to the presenters to answer during that time. If for some reason we're not able to get to that, I have a record of those questions. I'll be sure to work on getting those answers to you individually after our webinar. You can also let me know if you have any glitches or anything like that in the chat. I'll work my way through and trying to help you through that throughout the day. But do use the Q&A for questions for our presenters. And everybody should be on mute, so we should have a great day and ready to go. So without further ado, let me introduce Lilly Brooks, our Children's Tumor Foundation presenter, for our first presenter of the day.
Hello, everyone, and thank you so much for having me to this NF Symposium. As Ms. Rini Moss said, I'm Lilly Brooks, and I'm the 2021 National Ambassador for the Children's Tumor Foundation. I wanted to start off by thanking all the doctors and researchers for their countless efforts in their fights to end NF. I know that it means the world to me, and I know that it means the world to many others. I was diagnosed with NF at 18 months old, and I have tumors on my spine, neck, chest, and upper right arm. NF has also caused me scoliosis, vision problems, and other things. In 2016, I was given the opportunity to join the clinical trial, which led to the first ever approved Koselugo. This medication was amazing for me. It stopped my growth, and I've seen over 20% shrinkage. And it's also helped me be able to walk farther and do a lot more activities that people my age do. Despite everything NF has caused me, I have never let my diagnosis define me or what I can do as a person. I still graduated high school with distinction, and I'm still currently a sophomore at the University of Alabama and a proud member of the Alpha Delta Pi sorority. My goal as the ambassador was to be an example and show that NF does not have to stop us, and that we are not defined by our diagnosis, and we can still accomplish anything we put our minds to. So that is my message to many people out there that are just being diagnosed, or even if you've had NF for many years, that you can still do anything and you can still accomplish whatever you want. You do not have to be defined by your diagnosis. And I wanted to give a special thank you to Dr. Bruce Korf, because he was the one that diagnosed me and helped me find this clinical trial that has led to me being able to do so many different things. Thank you so much.
Thank you so much, Lilly, for being here. I know this has been an incredibly challenging year for any college student, but your resiliency and your courage in sharing your story with all of the NF community, we all appreciate it so much. So thank you for being here, and wish you the best as you return to college, hopefully in full speed soon, and safety as well. So thank you so much. Great. Wonderful. One other housekeeping to let you know, we are recording this webinar so that we can load this for future use for those that aren't able to join us today. So please be aware that we are recording that. And without further ado, I'm going to introduce our first speaker, Dr. Bruce Korf, who is the director of the Neurofibromatosis Program. Dr. Korf?
Okay, let me turn on my video. Hopefully that's showing, and I will share my screen. Give me just a moment. Let's see if that works. Are you able to see the slides okay?
Yes, we are. It's your,
all right, great. Okay.
Yes, you're great.
All right. Well, first of all, Rini, thank you very much for organizing this and for the introduction. And Lilly, thank you also for your words. It's really great to see you doing so well, and really exciting to see such a large number of people participating in today's webinar. Usually about once a year, we try to get together as a group at UAB to provide an update on neurofibromatosis, mostly expecting to see people from the local community participate. And it would be common to see about 40 or so people who spend the day at UAB and have a chance to meet each other and to listen to talks given by various of our staff. Obviously, these days, that's not so easy to do. And as a consequence, we really did feel there's a lot going on and things we would like to share with the community. So we decided to go ahead and do this virtually. And although no doubt we do miss the ability to get together, the kind of good side of this is that it has allowed far more people to participate than we've ever had before. And I think not only from our immediate community, but from a much wider area. And so we're really excited to see the participation today. Hope that you'll find this to be a useful and informative experience. You'll obviously miss the ability to network to the degree that we ideally would like to have, but I guess there are trade-offs. Well, I'm one of 3 speakers you'll hear from today. I'm going to try to give you kind of a big picture of things that are new and going on in the NF world. You'll be hearing, in addition, from Dr. Katie Metrock, who is a pediatric neuro-oncologist and who will speak about care of children with NF and clinical trials and treatments now that are available, and from Dr. Mina, Lobbous, who is an adult neuro-oncologist who will do the same from the adult point of view. And we may overlap a little with each other, though I don't think there'll be any harm in that. My goal is, as you see in front of you here, first to define neurofibromatosis. What is this group of conditions that we'll be talking about? Let's spend a little bit of time on how NF is diagnosed. You'll see that there is an ongoing effort to update the diagnostic criteria, and there's also a lot going on in the world of genetic diagnosis that I thought would be good to provide an update on. You'll be hearing from both Dr. Metrock and Dr. Lobbous about management of NF, so I'm not going to go into a great deal of detail about that, but I do want to give you a kind of snapshot of some of the critical things to watch for, just so you have a kind of checklist almost of what are the concerns that are important to be alert to. Treatment is, of course, really where we're all excited to be right now. The fact that there is an FDA-approved drug is, of course, a tremendous advance in the field, but it's only the beginning, we believe, of what I hope will be a pipeline of treatments. And although you'll be hearing about the specific treatments from Doctors Metrock and Lobbous, I want to give you a kind of big picture view of how treatments are being developed and where at least I hope things may be headed over the course of the upcoming years. So let me begin with a definition of neurofibromatosis. And as you probably know, neurofibromatosis really is a kind of umbrella term that encompasses, as far as we know, 3 distinct disorders, and they're distinct both clinically and from a genetic point of view. NF1 is the most common. It affects roughly 1 in 3,000 people, and that is true around the world. There doesn't seem to be any major difference in the frequency of NF1, or for that matter, the other forms of NF, no matter where you go. No particular place seems to have more or less of this, and probably that reflects the fact that half the cases occur due to a new genetic alteration, and these mutations could be happening in pretty much anybody, anywhere. NF1 we'll talk about in detail. It includes the brown spots on the skin, cafe au lait spots, neurofibromas that you can see either on or you can get a sense under the skin, but many other kinds of things that you'll hear more about a little bit from me and a fair bit more from Doctors Metrock and Lobbous. The gene for NF1 has now been known for, what, 31 years, I guess, and it is located on chromosome number 17. and really is the only gene that is responsible for, sort of bona fide NF1. The other two forms of NF are NF2 and schwannomatosis. I'll say right now that there is an international group, and I'll say a little bit more about it in a few minutes, that is looking to modify the nomenclature and seeking new ways of describing NF2 and schwannomatosis. And really the reason for this is the hallmark feature of NF2 are bilateral tumors of the hearing nerve called vestibular schwannomas. You can see this on an MRI here, probably a little bit more clearly on this side. Many other tumors occur, and we'll talk a little bit more later about what those are. And then there are schwannomas that can occur along peripheral nerves and other tumors called ependymomas. I'll say more about those later. But the hallmark of NF2, probably more than anything, is the schwannoma. And then there's schwannomatosis, which, as the name implies, you get schwannomas, a few of which are illustrated in this MRI scan in the chest in this person. And you don't generally get much of anything else, and you don't usually get the vestibular schwannomas that you see in NF2. Now we know the gene for NF2 is located on chromosome 22, shown, or its location shown here. So far, we know two genes that can cause schwannomatosis called LZTR1 and SMARCB1. They're both located very near each other, actually, on chromosome 22, and for that matter, quite near NF2. And we'll come back to that point because it's important in terms of how the tumors form. So you may wonder, why would three disorders all be classified as neurofibromatoses, even though only one of them, NF1, actually produces neurofibromas, because the tumors of NF2 and schwannomatosis are schwannomas. And in order to answer that, first of all, what is a neurofibroma? What is a schwannoma? Well, they're both tumors of the nerve sheath. You can think of a nerve analogous to a wire. It has a insulation that surrounds it. And in the case of nerves, the insulation is made primarily of cells called Schwann cells. And these are the origin of the tumors, and that's true in NF1, NF2, and schwannomatosis. However, the way the cells grow in NF1 is different than in either NF2 or schwannomatosis. The neurofibroma consists of Schwann cells, but a mixture of many other cell types as well. Whereas in NF2 and schwannomatosis, they're really primarily Schwann cell tumors, and they're called schwannomas, not neurofibromas. So why do we call all three of them forms of neurofibromatosis? Well, honestly, it's a historical issue as much as anything else. Until maybe the early 1960s, what we now call NF1 and NF2 were kind of mixed together, and there wasn't an appreciation of the distinction between the two. All that was really known is that they're both conditions that cause nerve sheath tumors to form. And the fine details of what kind of nerve sheath tumors, that took a while to sort out. And it became clear after a while that there really was a difference. You didn't see the hearing nerve tumors in people who had lots of the neurofibromas on their skin, okay? And you didn't see lots of neurofibromas on the skin in people who did have hearing nerve tumors. So there was a difference between the two. And gradually it got dissected out that there was this thing that for a while people called central NF, because it tended to involve more the central nervous system, but in fact, not a good name, because peripheral nerves, the nerves that come off the spine, were also involved. Sometimes it was called bilateral acoustic NF because the tumors on both hearing nerves, but it doesn't encompass the entire spectrum of tumors we see in NF2. People settled on NF2 actually in 1987 after there was a major conference that was put on by the NIH, which is also where the diagnostic criteria that have been in use since then came from. And that's how the NF1, NF2 nomenclature got started. Schwannomatosis actually wasn't recognized as a distinct entity, I think, until about the 1990s. And it wasn't named a form of neurofibromatosis per se. It kept its own name of schwannomatosis, but it was generally recognized also as a tumor, nerve sheath tumor producing condition. And that's how it got lumped under the neurofibromatoses. Well, there are many people who feel that naming a condition for neurofibromas that doesn't include neurofibromas as part of the condition, which is true for NF2 and schwannomatosis, doesn't make sense. So there is an ongoing international effort to think through whether these conditions should be kind of renamed. I'm not going to go into more detail about that today because this is still a work in progress, I believe, and I'll leave it to others as this kind of matures and is ready to discuss in detail. But you may notice in the next year or so some changes in the way we think about the naming of these conditions. By the way, NF2 seems to affect something like 1 in 30,000 people. Schwannomatosis, not sure we know the exact frequency, but it is probably in maybe the same order of magnitude as NF2, certainly not as common as NF1. All right, next let me take a look at how NF is diagnosed and actually especially some of the changes that are occurring in the diagnostic criteria. This is a long list, obviously, of the International Consensus Group on the Neurofibromatosis Diagnostic Criteria. The steering committee, shown over here to the left, are the group that have really kind of moved this forward. Scott Plotkin provided me some of the slides that I'll be showing. You can see it involves a very large number of people representing many different disciplines, seeking a consensus that experts who deal with NF every day would feel comfortable with. And this too is a work in progress. I think one of the sets of criteria should be published soon, and others are still in process, but expect they'll all be out within the coming months. But I do have their permission to at least give you a kind of a glimpse as to how things are going to evolve. Let me start with the diagnostic criteria we currently use. And so historically, NF, any form of it, we're looking at NF1 right now, has been viewed as a clinical diagnosis. I'll talk more about genetic testing in a few minutes. And so we've used these criteria since 1987, when that NIH conference I alluded to took place. And the agreement has been that anybody who has 2 or more features on this list can be diagnosed as having NF1, with the caveat, first of all, which was known from the very beginning, that some of these features take time to develop. So if you see a young child, let's say with cafe au lait spots, you don't necessarily expect to see neurofibromas on the skin, probably until later in childhood or adolescence or even beyond. So that particular criterion isn't always completely fulfilled until many years pass. So we were always dealing with the age dependency of these criteria, and by far the most common presentation of NF1 was through the cafe au lait spots. So that was one example of a challenge, and there were several others. As it was discovered, there are some other conditions that are associated with cafe au lait spots, for example. And I think it was things like this that motivated the community to get together and take a second look at the diagnostic criteria. I think what you'll find is they've been modified in some ways, although I would say it's more of a tweaking than a complete redo. And the criteria still have, for the most part, stood the test of time, but with some caveats. So let me show you what some of these are. Cafe au lait spots are the most common way for NF to come to attention, usually visible in the early months of life, occasionally even at birth, but more often they gradually show up in the first few months to even the first couple of years. I find that most people have as many cafe au lait spots as they're going to have by about age 2. They can vary in size from being a few millimeters to somewhat larger, even a few centimeters. As you can see, they have very distinct margins, typically. Pretty easy. You could, if you needed to, you could draw a kind of a line around this and show where the cafe au lait spot ends and more normal skin pigmentation picks up. They tend to be very sharp borders. The pigmentation is always a few shades darker than surrounding skin. So in people with darker skin, I don't find it usually that difficult to see the cafe au lait spots. In fact, I might argue the opposite. People with really fair skin, it can sometimes be a little tricky to see them clearly. Virtually everybody with NF1 has more than 6 cafe au lait spots, which is the criterion. And it isn't rare for anybody in the general population to have a few cafe au lait spots. Up to 6 even wouldn't be unheard of. 2 or 3 is not uncommon. Very often, cafe au lait spots not associated with NF have a much more irregular, fainter, kind of hard to distinguish background, or the edges look very jagged compared to NF1. And I can tell you there are a lot of people, and I hear from them on a pretty regular basis, who are sort of obsessed with the possibility their child might have NF because they have 2 or 3 cafe au lait spots that are irregularly shaped and really not the configuration we usually see in NF1. And I think in some cases it becomes almost an obsession, which is very hard to completely lay to rest because it's hard to prove somebody doesn't have NF1. But the cafe au lait spots with NF1 are usually pretty easy to distinguish and distinct and numerous. There are other conditions that can cause cafe au lait spots. Probably the chief among them is Legius syndrome, named for Eric Legius, who described it. And in that, you get cafe au lait spots and freckling under the arms and the groins at the base of the neck, just like you see in NF1, but you don't tend to see the tumors of NF1. Skin fold freckles are usually the second feature of NF1 to appear, most of the time between about 3 and 5 years of age. I tend to find them in the groin region usually sooner than in the region under the arms. And it's not just a cafe au lait spot or 2 in the region, like here's a cafe au lait spot in the neck. You wouldn't count that as a skin fold freckle. You can see the difference. These freckles are just that. They're really much smaller than cafe au lait spots and usually not present as early as cafe au lait spots. So here's the tweak in the diagnostic criteria now. It points out that if only cafe au lait macules and freckling are present, but still the diagnosis is most likely NF1. That's assuming it's of a sufficient number and size. But on some occasions, the person might have something else, such as Legius syndrome, which can be distinguished by genetic testing. I'll come back to that point later. There are some other much rarer conditions that can be associated with cafe au lait spots. Again, generally 6 or more. And this requires an expert who's familiar with these to diagnose. The other point that they've made now is at least one of the 2 signs, cafe au lait spots or freckling, should be on both sides. There are people that have all of their spots or freckles limited to one region of the body, which tends to indicate what we call mosaicism, where the genetic alteration happened during early development. So the person is a mixture of cells with and without the mutation. And so that can give the signs to be confined just to a limited region of the body. Neurofibromas are the next diagnostic criterion. They can be exceedingly numerous or fairly few, and there's no way to predict that. It's usually after puberty that they begin to grow in numbers, and during pregnancy in women. You sometimes can see them in young children, especially in side lighting, where they're not that obvious, but can show up, and not really worrisome to see them, but they can occur earlier than adolescence in some children. We also occasionally see something called xanthogranuloma, which is a common thing in children with NF1 in the first couple of years of life. I didn't bring a picture of one, but they usually have a yellowish orange tint, kind of a waxy appearance. They appear especially around the neck and face, around the hairline, but they can occur anywhere. They're benign. In fact, they generally disappear with time. Far more concerning would be plexiform neurofibromas. These are neurofibromas that arise from major nerves and involve the nerve and the branches of that nerve. You can often see this really irregular increased pigmentation, and that pigmentation will be there from birth. Thickening of the skin, as you can see here. You can track the neurofibroma, sometimes right down the nerve, and you can see the soft tissue overgrowth. Here's an example of an MRI scan showing the neurofibroma. Here's another MRI, and you sometimes see this little pale center or dark center, I guess, with the white tumor tissue surrounding it, which is a kind of characteristic feature that radiologists look for. So another area where the diagnostic criteria have been modified concerns the eye. Iris Lish nodules have been and remain a diagnostic criterion, 2 or more. They require a slit lamp, which is a kind of microscope that the ophthalmologist uses to see. So you can't see them reliably with the naked eye or with an ophthalmoscope and distinguish them reliably from other pigmentary changes in the iris. They're very useful, especially in older children and young adults where a high proportion have them. They have no impact on vision. The new thing to the diagnostic criteria are called choroidal anomalies or abnormalities. Choroid is in the back layer of the eye, and you really need an ophthalmoscope to see. And in fact, there's a technology that is used now in ophthalmology that picks them up. It is fairly straightforward to do, but it requires an experienced ophthalmologist to look for these. And they generally don't affect vision, but can be a diagnostic marker. The diagnostic criteria state that they are kind of an option to look for. It's not something that is going to add to the diagnosis if you already have cafe au lait spots, skin fold freckles, and Lish nodules. But in the absence of Lish nodules, the presence of these choroidal abnormalities can be a useful sign. Optic pathway glioma, they added the word pathway because there is a pathway from the eye, which is here, the optic nerve to the optic chiasm. These are MRI scans. This is a close-up view of the optic chiasm. And then all the way back to, well, this is not showing the right part of the brain, but all the way back to the occipital lobes. And any part of that can be involved in optic glioma. What you're looking at here is either enlargement of the optic nerves or the optic chiasm. And I think Dr. Metrock will talk more about diagnosis and management of optic glioma. I'll just say it can be a useful diagnostic criterion. And in the presence of these optic pathway tumors, very often, and you'll see them in about 15% of children with NF1, there's really no signs or symptoms, but we do need to monitor closely for visual changes and sometimes early onset of puberty. And otherwise, I'll leave to Dr. Metrock to talk more about these. There was a tweak in the diagnostic criteria for skeletal dysplasia. The most characteristic is this bowing of the tibia and the fibula. It really just defines it a little more precisely. It's not something I'm going to go into right now. It's probably more important for radiologists and physicians. We look for bowing of the lower leg, which, if it's going to happen, usually happens in the first year of life. The other diagnostic criterion with bone is sphenoid dysplasia. Sphenoid is the bone at the back of the eye socket, the orbit. You're looking at a CAT scan reconstruction of the base of the skull, and you can see this defect in the bone. And it is a characteristic skeletal dysplasia of NF1. Sometimes it's associated with neurofibroma in the orbit that can push the eye forwards. And if it is, you don't count both the plexiform neurofibroma and the sphenoid dysplasia as two separate criteria, because the two go hand in hand. But if you see sphenoid dysplasia, but you don't have a plexiform neurofibroma, which can occur, then the sphenoid dysplasia counts as a diagnostic criterion. And then genetics. The genetics of NF1, for that matter, NF2 and schwannomatosis is a dominant trait. Anybody who has it has a 50-50 chance of passing it to any of their children. It's transmitted from males or females to sons or daughters. And the severity and particular manifestations notoriously are variable from person to person in a family. Half the time we see a family like this where a child is born to two parents who are unaffected with NF1. And generally this is due to a new genetic alteration in the NF1 gene. And indeed, NF1 has one of the highest known rates of new mutation of any gene known to cause a medical problem. Not totally clear why that is. Part of it may be its size and the nature of the mutations, but there might be other reasons that are not yet known. In instances where it occurs sporadically like this, generally speaking, the parents have a low risk of recurrence if both parents truly are free of signs. Although what's called germline mosaicism or even somatic mosaicism sometimes can occur. So there might be another sperm or another egg either of the parents carries that could theoretically lead to a second child with NF. So it's not guaranteed that they wouldn't have another child with the condition. But the risk then tends to be low, not the 50-50 risk that you see when somebody is known to be affected. Their child who has NF, however, would have a 50-50 chance of passing it on to the next generation, something that that child is going to need to understand when he or she grows up. One point that was changed in the diagnostic criteria, it used to say that if you have a first-degree relative with NF, and then you had one other criterion, let's say cafe au lait spots, that the diagnosis was established. It's been changed that it needs to be a parent who's affected. Because you can have a SIB who's affected, and you could just by chance have a few cafe au lait spots and not have NF, and it could be erroneously diagnosed as NF because of your SIB. So the diagnostic criteria now require that the first degree relative is actually a parent. Well, let me say a few words about genetic testing, because in the original diagnostic criteria from 1987, genetic testing was really not a possibility. The gene at that point wasn't discovered, and it was way earlier than genetic testing was feasible. But much has changed since that time. And I'll credit Dr. Ludwig Messiaen here at UAB for having been the champion of that change. She really set up the first kind of practical clinical genetic test for NF1 and has been doing it here at UAB for, I guess, now close to about 18 years, and has amassed the world's largest collection of NF1 genetic variants. Something close to 3,000 different variants have been found in different individuals with NF1. It's a very large gene, and what's turning out is that the majority of the mutations simply inactivate the gene. When I say simply, I mean they turn it off so it can't function. And we'll say more in a minute as to how that happens, but that's the outcome. And remember, everybody has 2 copies of every gene. So we're talking about a change just in one of the 2 copies. And another point I'll return to in a few minutes. The pie chart here shows that there are many different kinds of mutations. So just kind of walking around this pie chart, missense means genes are really recipes that tell the cell how to make proteins, and a protein is a chain of building blocks called amino acids. And the particular genetic code determines the order of the particular amino acids. A missense is like a typographical error in the gene that causes the wrong amino acid to be inserted into the gene. And you can see here about 18% of the mutations are of this kind, where it leads to an abnormal protein, although it still can produce a protein. In fact, we know now that many of the proteins with these missense mutations are not stable in the cell, and they end up getting kind of destroyed just because they don't really function properly. 21% are nonsense. Nonsense means that there's a signal that the cell uses normally to tell the machinery that's making the protein that it has completed its work and the protein is done. Think of it as the period at the end of a sentence. Nonsense mutations change the genetic code so it puts the period in the middle of the sentence, and you end up with a partially formed protein, and that protein generally doesn't survive in the cell for various reasons. So nonsense mutations really completely turn off the gene. Frame shift means that there's been an insertion of 1 or 2 or sometimes more, or deletion of a similar number of letters of the genetic code. The genetic code reads 3-letter words, and if you change the code by something other than a multiple of 3, it completely alters the way things are read out. And that usually creates a protein that's also not functional. Intergenic copy number variants are just deletions or duplications of chunks of the gene. Splicing mutations are reflecting the fact that genes are encoded in segments and they have to be spliced together to produce the final functional version of the copy of the gene in RNA that's going to be read out as protein. And if there's a mutation in the gene that affects the way splicing is controlled, the splice will fail to happen the way it's supposed to. It often leads to skipping part of the gene and can completely alter its function. 5% have deletions of the entire gene, and it usually produces a quite severe form of NF, and a small number just have more complex mutations. So I'll tell you now, mutation testing is very readily available. It's certainly evolved a lot. Dr. Messiaen was really, as I mentioned, the pioneer in making it widely available. It's pretty easy to do. Costs have come down, and we use it more and more often, I can tell you now. It is now a part of the diagnostic criterion. So one of the criteria would be a known pathogenic mutation. That's a little bit tricky, and it requires an experienced lab to be sure that that's what it is, because genetic variation is common in general. Any gene you choose, no two people will probably have exactly the same genetic code, but most of those are variations that have no clinical significance. It's like the word gray being spelled G-R-A-Y or G-R-E-Y, doesn't really matter in terms of understanding. And the lab has to be careful to make sure that when it's finding a mutation that it believes is the cause of the condition, that they've correctly identified it and are not mixing it up with a benign variant. I think the testing labs have gotten pretty good at that, but it does require some sophistication in interpretation of the test. One thing you may wonder is, can we predict how NF is going to behave based on the mutation? The answer is usually not, with a few exceptions. And this is a list of what those exceptions are so far as we know right now. I don't think I'm going to read through every bit of this. I mentioned already these big deletions usually produce a pretty severe form of NF, lots of neurofibromas that start early in life. Different facial appearance, tall stature, which is sort of the opposite of what you usually see in NF. And we think an increased risk of malignant tumors now. There's good evidence for that, more than you see in the NF population in general. So it's not a common mutation, but an important one to recognize. Just as one example of the opposite end of the spectrum, there's one particular quite rare mutation which takes out one amino acid, but it's a deletion of 3 bases. And as a result, it doesn't change the reading frame, and you end up with a full protein minus 1 amino acid called methionine. And you can see cafe au lait spots, but you don't usually see tumors for some reason in that condition. And then there's a few others that are associated with particular phenotypes. I'm not going to go into a lot of detail about these. Generally, any one of these mutations is relatively infrequent. There aren't really major hotspots of mutation in the NF1 gene to speak of. And so most of the time, if we do mutation testing, it confirms the diagnosis, usually doesn't predict how NF is going to behave. Although there are some instances where we might suspect a kind of variant form of NF, for example, a form that affects mostly the internal nerves than the external nerves or externally visible ones on the skin. And sometimes mutation testing helps to distinguish that. But I think mutation testing is increasingly now available and being used in helping to establish the diagnosis, especially in a young child, because it can distinguish between NF1 and Legius syndrome, which I mentioned earlier, where Legius does not produce the risk of tumors that you tend to see in NF1. So I'm not going to go into lots of detail here, but just briefly mention NF2 diagnostic criteria. Remains the defining feature to see bilateral vestibular schwannomas, tumors of the hearing nerve. But here too, genetic testing now has a role in diagnostic criteria. One of the challenges here is that these tumors don't always form early in life. And if they haven't, then won't be useful as a diagnostic criterion. So they've divided major and minor criteria. Major criteria are more specific for NF2, minor maybe a little bit less so. Having a unilateral vestibular schwannoma would be a major criterion, but realize vestibular schwannomas in the general population are not that rare. And having a unilateral tumor by itself does not diagnose NF2. Having a parent generally with NF2 would be a major criterion. 2 or more meningiomas, tumors of the covering of the nervous system. and then an NF2 pathogenic variant in unaffected tissue like blood. The minor criteria are tumors you can see in NF1, I'm sorry, in NF2 rather, which aren't considered specific enough. Cataract, for example, can be a sign of NF2, but of course it can also occur in the general population. Some of the things you see in NF2, this is an MRI showing vestibular schwannomas on both sides. I think you'll hear more about some of this from Dr. Lobbous. Here's a meningioma, a tumor of the covering of the nervous system, an ependymoma, a tumor that occurs within the spine, typically. Oops, and it's a little hard to see. It's not a great picture, but you can see schwannomas in the skin. They show up as plaques. They're really not the same as neurofibromas. They look different. Sometimes there'll be a few hairs growing from them. They're not painful generally, but people with NF2 sometimes will develop those. And there are some degrees of genotype, phenotype correlations in NF2, certain kinds of mutations more likely to produce earlier onset and more rapid progression. Genetic testing for schwannomatosis is a more complicated terrain. Unlike NF1 and NF2, where we say the penetrance is complete, which means person who has the mutation in all of the cells of their body is pretty much guaranteed to develop the signs, maybe more or less, but still they're going to have it. Schwannomatosis tends to be a little bit more elusive. You can have this gene variant and maybe never develop a schwannoma, or have just a few, or have a fairly large number. What's going on in schwannomatosis is pretty complicated. I mentioned the SMARCB1 gene as one gene that can be associated with schwannomatosis. And what's shown here in red is it's mutated. So this is a germline mutation. You have 2 copies of every gene, and for that matter, every chromosome other than the X and the Y, of course. And in the germline, so here's 1 copy of 22, here's the other, and 1 mutation in SMARCB1. This by itself does not produce a tumor, and every cell in the body would look like this. What we tend to find if you look at the tumors in schwannomatosis is that, well, that original SMARCB1 gene mutation is going to still be there. NF2, which is nearby, is also mutated in the tumor, not in other tissues. And furthermore, very often the other copy of chromosome 22 has a deletion that encompasses both SMARCB1 and NF2. So in order to get a tumor, actually, 2 things have to happen. The other copy of NF2 has to be lost, and the other copy of SMARCB1 and NF2 have to be lost. And that may be why the tumors are less common in schwannomatosis than they are in NF2 or NF1, because it takes multiple events to produce a schwannoma in schwannomatosis, which is not so in NF2, and it wouldn't be so for neurofibromas in NF1. And the mechanism for LZTR1 is very similar. Not everybody with schwannomatosis has SMARCB1 or LZTR1 mutations, and there may be other genes yet to be discovered that account for that. The other thing is that both NF2 and schwannomatosis are commonly involved in mosaicism, where you may get restricted regions of the body or restricted numbers of tumors or just restricted numbers of cells. And if blood cells are not among the cells that are carrying the mutation, you might not be able to detect it in the most typical tissue, which is blood or sometimes saliva. So it can be elusive to find these mutations, and genetic testing is not always positive. Tumor testing can be helpful, although it can be sometimes challenging to organize on a clinical basis. Well, I'm not going to talk in great detail about management of NF because you'll hear lots more about it. I just wanted to point out there are some age-related things. Plexiform neurofibromas and bone dysplasia, especially tibial, are pretty early in onset. They might be subtle early on and require some experience to pick them up. But we think that these are generally either congenital or visible in the early months of life. In childhood, be alert to the juvenile xanthogranuloma, not because they're going to change anything much in care, but just not to be alarmed about them and to assume that they're neurofibromas. You definitely need to be monitoring for loss of vision. A young child will not tell you that they can't see. It's one of the reasons why we recommend ophthalmology evaluations. Early puberty or growth spurt that's happening sooner than it should could be a sign of optic glioma, because the part of the brain that controls hormone secretion is sometimes involved with the optic tumors. A lot of children with NF1 have low muscle tone. They tend to have kind of a little bit floppy muscles. Their bellies seem to protrude because the muscle tone in their abdominal wall is decreased. Learning disabilities, problems with speech and language, and attention deficit disorder with or without hyperactivity, very common, and really makes it important to pay attention to learning and really get an evaluation if there's concern about that. We monitor blood pressure, especially because the artery to the kidneys can be narrowed and cause high blood pressure. It's not that rare to see headaches at any age in NF1, including in children. Sometimes they also cause stomach aches, interestingly, even though the origin may be in the nervous system, and sometimes recurrent vomiting. Most of the time it's benign. Of course, you do want to investigate the possibility of a growth in the brain. And also sometimes there's a thing called Chiari malformation, where the base of the brain is kind of pulled down below the kind of hole between the brain and the spinal cord. And that, if it's significant, sometimes requires surgical treatment. We tend to monitor vitamin D levels now. It's been learned that sometimes these are low, and that maybe contributes to the development ultimately of under-mineralized bones. And most plexiform neurofibromas seem to grow in childhood. Things to watch for in adolescence, at any time in life, really: unexplained pain that just doesn't go away. Dr. Lobbous will talk more about malignant peripheral nerve sheath tumor, but that, or tumors that are growing disproportionately or becoming hard where they used to be soft. I know Dr. Lobbous will talk about the glomus tumors that can cause really excruciating pain in the fingertips or the tips of the toes. Want to be alert to episodes of heart racing, palpitations, flushing, and hypertension. A tumor of the adrenal gland called pheochromocytoma can present that way. Lung involvement with NF1 is not common, but it does occur. Of course, the cutaneous tumors I've talked about, and you'll hear more from Dr. Lobbous. Headache, again, might be migraine, but it could also be something more serious and needs to be paid attention to. Weakness, numbness, indicating pressure on a nerve. Osteoporosis, continued monitoring of vitamin D levels. We've learned that women with NF1 are at increased risk of breast cancer, so monitoring is recommended to begin at about age 30. NF2, you're watching for loss of hearing, of course, ringing or other odd sounds in the ears, headaches, facial weakness, because the facial nerve runs right next to the vestibular nerve and can cause drooping of the mouth, for example. Episodes of weakness or numbness in various parts of the body, visual changes suggestive of cataract. And schwannomatosis, mainly you're watching for pain. And the pain can be hard to treat in schwannomatosis, though it tends to respond to surgery, but sometimes that surgery isn't so easy to do, depending on where the tumor is. Well, in the last few minutes, let me just get into where we're headed with treatment. All of these disorders are what we call tumor suppressor disorders. I illustrated here for NF1, but it equally applies to NF2 and schwannomatosis. I've already shown you the complex mechanism. A person with NF1 has one intact copy of the gene shown by a plus, one mutated copy of the gene shown by the minus in every cell of their body. What seems to happen in a neurofibroma is just a random genetic change takes this intact copy and mutates it as well. And once that's happened, this is a Schwann cell now that's abnormal, and it will grow, but it also stimulates other cells in its environment to grow too. And that's what produces the neurofibroma. And to get to a malignant tumor, we now know that there are changes that accumulate on top of this, which release the cell from its normal growth control. Well, the ability to treat NF1 has really been revolutionized by understanding the cellular mechanism. NF1 is a controller of a protein called RAS. RAS is a kind of switch in the cell. When a signal shown by this little ball binds to a kind of antenna in the cell membrane, it activates RAS, which causes it to bind with GTP, a molecule that is attached to RAS. And when that happens, it causes a chain reaction, stimulating various other proteins, eventually causing one to migrate to the cell nucleus, and it alters the way genes are activated or suppressed, which can lead the cell to grow. NF1 is essentially a control point here, and it causes the RAS GTP to be converted to RAS GDP, which inactivates RAS. So NF1 is like the off switch telling the cell not to grow anymore. So you can imagine if you're missing NF1, both copies of it, as you are in a tumor, RAS, once it's turned on, can't be turned off, and it just keeps signaling. And that's best we can tell really what does happen. And so it's spawned the question, can you inhibit this pathway? To make a very long story short, yes, you can. And that's what the MEK inhibitors do, including selumetinib, the now FDA approved drug, which blocks the conversion from this thing called MEK down to the next protein in the chain reaction. And when that happens, it indeed does turn off this pathway, and it has been shown to be effective in actually ceasing and even in many cases reversing the growth of plexiform neurofibromas. And you'll hear more about that in a little bit. If you think really broadly, where are the potential points of intervention? If you start with the one copy of the NF1 gene being intact, then you lose that copy. It increases RAS signaling, it increases other signaling pathways, and you get a neurofibroma. It would be nice if we could prevent that second hit from ever occurring. I don't think anybody has a good idea how we might do that. Maybe you could restore the function of the mutated gene, though, or you can inhibit RAS signaling. That's what MEK inhibitors do, or maybe block other signaling pathways. So you've heard about the MEK inhibitors. Those were developed actually by originally a consortium that was funded by the Children's Tumor Foundation to develop animal models and to test them with drugs. And it was discovered that selumetinib actually was effective in these animal models. And that in turn led the group at the National Cancer Institute to do a clinical trial. And ultimately they recruited a couple of other sites to participate. And that's eventually what led to the FDA approval of selumetinib. Meanwhile, the Department of Defense now since 2007 has funded the NF Clinical Trials Consortium. I know Dr. Lobbous will talk a bit more about this as well. UAB is the coordinating center for this consortium, and all the different sites are shown here. The colors just indicate when they join the consortium. And UAB also does all the data management for the consortium. So without going into detail, because there's way more here than I can take the time to talk about, this is a complete accounting of the clinical trials that the consortium has done since the onset in 2007. The first trial was launched in 2008. The ones shown in gray are targeted to NF1. The ones in green are for NF2. You can see there have been more for NF1 than NF2. The ones above the bars show things that the consortium did solo. The ones below were collaborations with various groups, especially the Sarcoma Alliance for Research and called SARC. And mostly that's been for the malignant tumors. We have several trials that are either in progress right now or in development, and this will be a continuing sort of pipeline. So in the last couple of minutes, let me just say a few words about some of the work being done at UAB. We're back to the pie chart of the mutations. And one of the things we've been interested in is there a way you could possibly, well, let's say fix the mutation in one form or another? Can you trick the cell into not noticing the mutation? Or can you develop drugs that lead the mutation to not affect the function of the protein? Or what everybody would really love is, can you literally get in the cell and edit the mutation out, fix the typographical error? I think of this as very long-term kind of planning. This is not something that's going to happen overnight. So actually, here's a couple of other strategies, but this is a slide that Dr. Bob Kesterson in the UAB Department of Genetics gave to me. He has been creating animal models of NF1. Most of the animal models that have been used historically just completely knock out the gene, and not in a way that's similar to what actually happens in people. What he's been doing is putting human mutations into the mouse, and many of them indeed do develop neurofibromas. The list, this is actually an old slide, and the list is expanded. But he's been developing these models so we can test some of these different systems. Dr. Deanne Wallace also working in genetics, and Dr. Andre Lear in genetics, Dr. David Bedwell in biochemistry and molecular genetics at UAB, all are involved in trying to develop approaches to this kind of what we call mutation-guided or genomic-guided therapeutics. We don't have treatments that we think are going to be ready for the clinic right away, but we think in a long-term way that this may have a place in treatment to restore function in one form or another. There's a lot of interest these days in genome editing. You know, you've probably heard of the CRISPR-Cas9 system, which actually was the subject of last year's Nobel Prize in chemistry. It's a way of really surgically editing the genome, and consists of an enzyme called Cas9 and then a guide RNA, which uses nucleotide base pairing to find a site and makes a precise cut. And then you can repair it with DNA of choice. And in fact, there is now an effort, and Dr. Kesterson is part of this, to develop genome editing approaches. Let me tell you, we use it every day, or he does, in the laboratory to develop these model systems. So it's not, you know, new esoteric technology, but getting it to work in cells inside the body and to target it appropriately, that's a much more challenging kind of thing to do. So this is very early stage work that's going on, although in the long run, we're hopeful it will find some role in the therapeutic sort of armamentarium. So let me end here with kind of where I think the future of NF care is going. I mentioned three things. What I call smart surveillance, as we learn more and more why some people get opticgliomas and some don't, maybe, or what are the early signs of malignant peripheral nerve sheath tumor. And far better than treating it would be preventing it, or catching it really early when it's easy to remove surgically, as opposed to waiting for it to have advanced to a point where it can't be surgically treated. So trying to tailor surveillance to the individual, doing just the right amount, you know, not overdoing it, doing tests that are not going to be productive, but also not ignoring signs that really need attention. Targeted, precise treatments. This is really where the world of medicine is going in general, and NF already has achieved that to a degree with selumetinib, but I think we'll see more and more examples of that in the coming years. And I really would emphasize the importance of community building, support provided patient to patient, collecting real-time data from the patient community to learn as we go about some of the early signs of various complications, and trying to work on issues of access to care, which we realize is not evenly distributed around the world, and certainly even around the country. Just a quick word about the UAB NF program, and then I'll stop. We have now 3 sites for clinical care: the Whitaker Clinic, which we hope to be opening again soon. We've been doing telemedicine during the COVID pandemic, but we are planning to open, we hope in May, assuming things continue along a positive track with COVID and vaccination. Both myself and Tammy Skelton, a nurse practitioner, see children and adults. You'll hear in a few minutes from Dr. Mina, Lobbous, in adult neuro-oncology. He sees patients, various sites, and Dr. Katie Metrock at Children's of Alabama sees children for mainly tumors. The UAB Medical Genomics Laboratory continues to be a leader in genetic testing. I mentioned the NF Clinical Trials Consortium. Want to acknowledge Dr. Yurish Dahl, head of Pediatric Oncology at Children's of Alabama, and is the deputy director of our operations center. And I already mentioned some of the laboratory research, animal models, therapeutic development, and both informatics and some work on RNA editing I didn't have time to talk about with Dr. Lyer. So I'm going to stop at this. Just mention our website, which is undergoing some revision, and I'll point to you the blog that I try to do every month, or approximately that frequency, just to kind of reflect on issues in NF. And we're going to try at some point to index it we've been doing it now for several years. So a fair number of things have accumulated there, but it's a place to go for current sort of thinking about NF. And with that, thank you. And I guess I'll turn it back to Rini to introduce the next speaker.
Thank you, Dr. Korf. We have a little bit of time for some questions. Some of these questions, Dr. Lobbous, I think, is going to cover in his presentation, but Dr. Korf, why don't I give you two right now, just since they're fresh. If an NF1 diagnosis has been given, is there any benefit to completing genetic testing to confirm?
Yeah, so I guess the answer depends a little on the situation. If the diagnosis is clear, and I mean by that, cafe au lait spots, the presence of neurofibromas, for example, where there's no question about whether it could possibly be Legius syndrome, for example. You're not going to make a better diagnosis because you have genetic testing than you would have otherwise made because it's NF1. There are some circumstances I alluded to where there are some genotype phenotype correlations, like if you suspect the large deletion, for example, we do kind of keep a special watch on those patients. And I think there is benefit to genetic testing there. There are certain kinds of mutations that seem to predict the spinal tumors occurring more frequently. So there's some value to that. It has value for genetic counseling purposes in terms of informing other family members, first of all, whether the gene's been passed on, if there's any question, although usually you can tell clinically. And also, it does open the door for families interested in prenatal testing. So I would say that it's not going to probably change the diagnosis in most instances, unless there's some uncertainty about it, in which case then it is valuable. But it can provide other valuable information. I'll be honest, I'm doing it more and more. It's gotten easier and easier to do. And it's pretty common in medicine to try to nail things as precisely as you can. But I can't honestly say it will always change the diagnosis, although there are instances where a diagnosis is suspected and it doesn't turn out to be what you thought. So I guess I'll give you a kind of tentative. I really think it's increasingly being used, but I don't think it's absolutely mandatory to make a diagnosis.
Furthermore, I know this question comes up a lot in terms of additional family members. If there is a genetic test that confirms a diagnosis in a child, are there opportunities to test parents or family members? Do you know the financial cost of that in terms of cascade testing within a family if additional decision-making is associated with that family?
Yeah, so it is possible to test the parents of a child who's been diagnosed. Occasionally, we'll do that actually to make sure that the mutation that has been found in the child is really the cause of the NF. Just think back to the pie chart. I mentioned missense mutations. Well, the challenge with missense mutations is they don't completely turn the gene off, most of the time at least. And there are some that are mutations that might never have been seen before. And it raises a question, how do we know this really is the cause of NF in that person? And we'll often test the parents, assuming the parents don't have NF, to make sure they don't carry it, because you figure, well, if it's a benign variant that's not causing NF, then maybe one of the parents also carries it but doesn't have NF. And so it can be very valuable to look at the parents, assuming they're not affected, and make sure they don't carry this variant, because if they do, it's probably not the cause of the NF in the child. So that's one reason we might test the parents. We don't do that if it's a mutation that's pretty well known to completely turn off the gene, because it's not that difficult to figure out that it is the cause of NF in those instances. If a child is the first affected member of the family and you test the parents, let's say it's for a mutation that you already for sure know is causing NF, you're almost sure to find that they don't carry the mutation, because if they don't have signs of the condition, it's very unlikely you're going to see the mutation in blood, which is the usual tissue, or saliva these days. Because if you carry this mutation, you're pretty sure to show signs of it. And so blood or saliva testing usually will be negative if the parents are really free of signs. I mentioned mosaicism before, where you can have a mixture of cells in your body with and without the mutation. And in theory, those can occur just in the germline, sperm or egg cells. And if so, you're not going to pick it up unless you test sperm or egg. You can do that in a male. It's pretty hard to do it in a female. And it's not routine to do it in either one. So a negative test in the parent doesn't prove that they don't have some cells somewhere with a mutation. In practice, if the parents really don't have cafe au lait spots or neurofibromas, we've learned that the risk of their having a second affected child is really low. How low? You know, you'd like to say it's back to the 1 in 3,000. I'm not able to go that low. I usually tell people it's probably 1% or so, and that's sort of, to be honest, a made-up number. It just means it's unlikely but not impossible. I will say that if they were concerned about prenatal testing or even pre-implantation testing, if you know the mutation, you can offer that, and you will know the mutation if they've had an affected child. For cascade testing, I guess the test is easier to do than the original test because you know in advance what you're looking for, so it's a targeted test. You don't have to sequence the whole NF gene to find the mutation. So it's usually a lower cost test. You know, telling you what the cost is a little hard because it depends on where it's done. Different labs might have different pricing structures. If it's covered by insurance, it all depends on your insurance and how they cover those kinds of things. So it's hard to give a generalization, although I will say it's usually less expensive than the original test where you had to sequence the entire gene to find the mutation.
One more question related to genetic testing. There are a number of questions I think that are going to be answered by Dr. Lobbous and Dr. Metrock, so I'm going to hold those. But the other one is, if you've had a genetic test more than 10 years ago, is there any value in doing it again?
Well, I think that depends on, well, it really depends on what was found and the nature of the test. So it's true that the technology that we use for testing today has evolved some from what was offered, let's say in the UAB lab 10 years ago. We did do it by a different method, but that the improvement in the method is probably mainly in terms of simplicity of doing the test, the ease of interpretation, and it's been informed by more than a decade of experience of where to look for the mutations. But I don't really think that it's a better test in terms of being more reliable. It might be more sensitive if mosaicism is suspected. But the bottom line is, if you had a test done, let's say at the UAB lab, in 2005, and a particular mutation was found, there really is not much point in repeating it because that mutation is not going to change. And the accuracy of the testing back then was just as good as it is today. The only caveat to that is, in the years before the UAB lab set up the test, there were some commercial labs that were doing a different kind of testing, and they weren't actually finding the mutation. They were, in a way, inferring its presence from the way the messenger RNA, which is the copy of the DNA used to make the protein, the way it was kind of formed. And they gave an answer that yes, it was, or no, it wasn't abnormal. And they would say what region was abnormal, but they wouldn't say what the mutation was. And although I don't know that the test was inaccurate, it wasn't nearly as complete as what is available today. So if you had a test that defined the mutation, and it should be equally valid now as it was before. If you had something that didn't, it might be worth rethinking it, given the evolution of the technology. And if you had NF fulfilling diagnostic criteria, but negative testing, that's probably worth revisiting for a few reasons. One is the test is more sensitive now. We're somewhat better able to pick up mosaicism, though not always. So that still leaves gaps. There are some examples of things that resemble NF that have been identified that are due to mutations in genes other than NF1. So a family of disorders called RASopathies, for example. There's one called Noonan syndrome. You know, I've found a few people that had cafe au lait spots and some freckling where I thought maybe it was NF1. They never developed neurofibromas. And then years later did testing and discovered it was actually this other condition called Noonan syndrome, which is a different genetic condition, although it's got some overlap in features with NF1. So if your testing was negative, but you really fulfilled criteria, that might be worth revisiting. But if it was positive for a particular mutation, we have no reason to expect that to change.
Great. Thank you, Dr. Korf. There's a number of additional questions. I think some of these, Dr. Lobbous, you're able to view them and they probably will come up in your presentation. If not, and if we have time, I'll moderate and give those questions at the end of your talk. So without further ado, let me introduce Dr. Mina Lobbous, a neuro-oncologist working with the adults with the UAB medicine. Dr. Lobbous.
Thank you. Good morning, everyone, and thanks for joining us in this beautiful Saturday morning. Thanks for the Children's Tumor Foundation for making this happen, and we look forward to seeing you in person soon. So let me share my screen. Good. Okay. So this is my disclosure. I'll be discussing off-label therapeutics, and I'll explain to you what this means. Just forgive me if I echo some of what Dr. Korf have mentioned. You know, there's some overlap in the presentation, but I will try to just go briefly, not take too long of your time. So the objectives of the talk will go over the adult care, NF1, NF2, and schwannomatosis. We'll talk about therapeutics approaches and clinical trials and future directions. So we'll start with neurofibromatosis type 1. As Dr. Korf mentioned, the incidence is about 1 in 3,000. 50% of the people we see in clinic, they are the first in their family to have neurofibromatosis type 1. We call this de novo. This is an autosomal dominant disorder, meaning it does not skip generation, and the gene responsible for that is on the chromosome 17. And as Dr. Korf elaborated on the genetic testing, that's now more available and easy to do. The diagnostic criteria for NF type 1 need to have more than 2 of these manifestations: cafe au lait spots, the freckles, neurofibromas, the iris nodules, optic gliomas, musculoskeletal or skeletal dysplasia, and the first degree, the parents, Dr. Korf mentioned. When we look at the neurofibromatosis manifestations, kind of differ by age. Some of the manifestations become more prominent, some of the manifestations kind of regress. So in children, and Dr. Metrock will go over this, we see the cafe au lait spots, we see the tibial dysplasia, we see plexiform neurofibromas. Adolescents, we can see scoliosis, we can see optic gliomas, we can see the retinal artery stenosis. And then in adults, we still see the plexiform neurofibromas. See here the optic nerve tumors, the vision nerve tumors, less problematic in adults. We see higher risk of breast cancer. We see the painful fingertips tumors that's called Lobbous tumors. This is a table of the NF1 manifestations, and you can see that's here divided to like birth, preschool, school age, adolescents, and adults. I'll be talking more about the adolescents and adults. osteopenia, the cutaneous neurofibromas, spinal neurofibromas, plexiform neurofibromas, and the cerebrovascular, like coronary artery stenosis or hypertension, and tumors like malignant peripheral nerve sheath tumor or glomus tumors. We'll start with the cutaneous neurofibromas. It's most common growth in people with NF1. They differ from one to another. In terms of age presentation, in terms of the location, the distribution. Itching is common, and there could have a substantial impact on quality of life. So, and again, the distribution and the symptoms that come with it is really what kind of impact the quality of life or kind of treatment options. So there are some local, I would say, approaches to treat these tumors through our dermatology colleagues, like surgical excision or laser or radio frequency ablation. And we will mention the clinical trials and off-label therapies in a second. Plexiform neurofibromas, can arise from any peripheral nerve, affect about 50% of people with NF1, and they tend to grow more rapidly in early childhood. I'm showing you here an MRI. This is the brain and this is the neck, and you can see this plexiform neurofibromas. They are benign tumors, but they can be problematic if they push on a nerve and can cause pain or weakness or numbness or other sensory changes. So though they are benign, they can be problematic. And if they grow further, they can be disabling or disfiguring. Really, surgical excision, like surgeon cannot just shut it out. Total surgical resection is very, very challenging in these tumors, given the nature of them. Spinal neurofibromas, these are the neurofibromas that arise from the nerves exiting our spinal cord. You see here this MRI. This is a lower, on the left is the lower back MRI. On the middle here, you see the neck area, and here all the way to the right, you see a horizontal picture of the spinal cord, and you see these tumors in white color exit, like wrapped around the nerves, exiting the spinal cord. They can manifest with pain again, or weakness or other sensory changes. And there are subset of people with NF1s that tend to have more of these internal or spinal neurofibromas and less of the cutaneous manifestation, like the cutaneous neurofibromas. Gliomas is another, other tumors that can arise in neurofibromatosis type 1. These are primary central nervous system tumors, meaning they arise within the brain or the spinal cord. They don't arise elsewhere and travel to the brain. The most common form of glioma, as Dr. Korf mentioned, is the optic pathway glioma. And optic pathway glioma, if you can, this is here horizontal picture, an MRI picture, and you can see the eyes here, the nerve behind the eyes. And they kind of regress in adults, so they arise in children and can progress, but more likely to regress in adults. And Dr. Metrock will go over the optic pathway glioma. These can be malignant. Like here's the MRIs that I'm showing you here in the middle. You can see this white lesion in the back of the brain. That's a malignant glioma. So in rare circumstances, these tumors can behave behave aggressively, and that can, we have to take this out, surgery or biopsy and treat it at the same way we treat malignant glioma. So they're not always benign and can be quite problematic in adults. Malignant peripheral nerve sheath tumor, NF1 carry lifetime risk of malignancy at about 15 to 20%, and the majority of this is due to the malignant peripheral nerve sheath tumor, which the risk to develop that is about 10%. Things to watch for if there is any, as Dr. Korf mentioned, unexplained pain, rapid growth, the tumor turn into more firm or tender when you push on it. All of this, you bring this up immediately to your physician, because that warrant further workup. As you see here on this picture, that's a picture of a PET scan. So a PET scan basically used like a radioactive tracer. We inject it into the blood, and we look at the basically tissue activity, and most likely cancerous or malignant cells have the increased activity, so they light up on the PET scan, and that will raise a concern of malignant peripheral nerve sheath tumor. Really, the treatment try to take out as much as possible surgically with what we call wide margin, like takes the tumor and the surrounding tissue. Make sure you're not leaving any tumor cells behind. If this is not feasible because of the location or because of risk of injury to other organs, radiation therapy is an option. Cytotoxic chemotherapy, like infusion, like vincristine, ifosfamide, this agent can be used to treat malignant peripheral nerve sheath tumor. But I can't emphasize enough on the importance of bringing up any of these warning symptoms. Do not just put them off and say, oh, I'll take some Tylenol or some pain meds. If something changed, bring it up to your doctors. Epilepsy, risk of seizures in people with NF1 can be anywhere from 4 to 7%, and that's higher than people without NF1. People without NF1 has a risk of about 3%. So NF1 comes with a higher risk of having seizures. The onset of seizures can occur really at any age. It can be generalized tonic-clonic seizure, it can be focal seizures, can be absent seizures. The studies that were done found that the most common type is the focal seizure. They can be in a form of just a group of muscle twitching, like the face, the arms, the leg. Again, if you develop any of these symptoms, bring it up to your doctors, because the workup, we do this brainwave testing. We call it EEG. We do a brain imaging, a CAT scan, or most likely an MRI. Make sure we're not missing any brain abnormalities that will be causing these short circuits, basically, that's leading to the seizures, and blood work as well, because sometimes just electrolytes imbalances can provoke a seizures, or some hormonal changes as well. There are several lines of treatments. There are, every year or so there are newer anti-seizure medication that's well tolerated with less side effects. There are even, there are devices, there are surgeries. We typically start with medications, and if the seizures continue to happen despite the medications, then we have, again, different lines of treatments. Blood pressure issues in neurofibromatosis type 1 can be essential hypertension. Essential hypertension is basically high blood pressure without identifying a reason, which is the most common type of hypertension. The other disorder we look at in NF1 is pheochromocytoma. So pheochromocytoma is a tumor. See here, this MRI in the middle here, there's the spine, the discs, and there's the kidneys, and then on top of these kidneys there is a lesion here. I hope you can appreciate it on this MRI, and that's these are lesions that secrete chemicals that can cause the blood pressure to be high. It can manifest in lightheadedness, new onset headache. Sometimes we see this fluctuating blood pressure. You know, it's high, and then it go down on its own, and then go up again. And if it left untreated, it can cause more problems like chest pain or, God forbid, a stroke. It's very important to have at least annual check that include blood pressure measurement. The risk of pheochromocytoma is 1% or less in people with NF1. The other disorder that can lead to high blood pressure is the renal artery stenosis. If you see in this graph, this is the artery and then the kidneys on both sides, and you can see the blood vessels that's or the artery that's going to this kidney is narrower compared to the other one. And in this case, the blood pressure, the kidney reflexively increase the blood pressure, and we do the work like anyone with anyone with NF1 with newly diagnosed high blood pressure. We have to look at these pheochromocytoma. We send certain blood work called metanephrines. We get abdomen imaging. For renal artery stenosis, we get an ultrasound. We get a specific MRI called MR angiogram, which is basically visualizing the arteries or the blood vessels going to the kidneys. And that if either of these are found, we treat it accordingly, either surgical or with medication. But the risk for either of these is about 1% or less. A couple of years ago, the American College of Medical Genetics and Genomics published these guidelines. Dr. Stewart, Dr. Korf, and colleagues came with this very, very helpful practice guidelines to help physician kind of plan the care for adults with NF1. I'm just gonna go over them, and that may answer some of the questions that were just sent. So basically, the summary for malignant peripheral nerve sheath tumors, it has to be looked at, evaluated, and treated in specialized centers that's familiar with this type of tumors. The question, shall we just image every single plexiform neurofibromas to make sure it doesn't turn malignant? It's a matter of clinical judgment, because imaging a plexiform neurofibromas that's not causing symptoms less likely to be productive. And you know, if it's not causing symptoms, why you put someone through all this imaging or interventions that may carry more risks than benefits. When it comes to any soft tissue tumor, if it's neurofibroma, schwannomas, malignant peripheral nerve sheath tumor, MRI is always preferred over a CAT scan. It's more accurate, less risk of ionizing radiation. CAT scans are better when it comes to the bone, but for the soft tissue, MRI is preferred. Breast cancer, women with NF1 has a higher risk of developing breast tumors, and we advise that the annual mammogram start earlier than people without NF1, and that should start at age of 30, alternating between mammogram, which is the X-ray, and MRI, which has higher accuracy in detecting these tumors even in an earlier stage. As I mentioned about pheochromocytoma, it can happen in people with NF1. We do the workup for new onset high blood pressure or new diagnosis of hypertension in adults and pregnant women, and or those who have symptoms. There's blood works or imaging to do that, and then we treat it usually surgical if it's causing problem, and it's a simple blood test that can detect these tumors. As I mentioned, also high blood pressure. High blood pressure in NF1 should be taken seriously, because if it's left untreated, it can cause problems like, God forbid, a heart attack or strokes. So we do the workup, either imaging, blood work, and then we treat it accordingly. And as I mentioned, the MRA is basically the MR angiogram, which gives a detailed picture of the blood vessels that's going to the kidneys. Bone health, we advise on using vitamin D supplements to get the vitamin D level in the blood to the sufficient range. Usually this in 25 or above. It depends on the reference that the lab is using. Osteoporosis can occur in earlier age in adult with NF1. And then as Dr. Korf mentioned, the risk of the bowing or the scoliosis in children and adolescents, typically monitor people with NF1 for scoliosis, and if there is any surgical correction that's based on the curve progression, is it getting worse? I mean, if it's stable, and not causing a problem, we leave it alone, because these surgeries can be quite invasive. Cutaneous neurofibromas, the current treatment, if these are problematic, meaning bothersome in terms of the itching or causing an impact on quality of life or disfigurement, surgery is an option, laser removal, and there are clinical trials that I will get to in a second that address the cutaneous neurofibromas. Neurocognitive function in adults, there are really limited data on the ADHD in adults with NF1. Typically, if we see an adult NF1 with no prior history of cognitive problem or learning disability, and then they start developing cognitive changes, that really push us to do more workup to look for other etiologies other than NF1. Is it something, like brain imaging? Is it certain vitamin deficiency? Are there hormonal changes? Are there seizures that we need to look at? Neurological issues and NF1, as Dr. Korf mentioned, headache can happen in NF1. It can be migraine, it can be tension headache. There's higher risk of seizures, as I mentioned. Sleep disorder, like someone who has plexiform neurofibromas that's pushing on the airway, that's causing them to snore at night, causing sleep apnea. We typically treat these as same way we treat in people without NF1. I'm putting this MRI picture here. You can see this bright white color. This is one of the tumors that come in adults. It's called glomus tumors. These are benign tumor, but can be quite painful, and they are raised kind of a fingertip or two. The toenails can be quite painful, and treatment for these are usually surgical. Reproductive health in NF1, and So someone asked about this. First, we have to, we educate all our patient that's if you have NF1, even if you are in the first one in the family to have NF1, there is a 50% chance to pass this to your kids. If the pregnancy is not desired, then contraception should be used. The options kind of before pregnancy is a pre-implantation genetic diagnosis. Basically, it's more of collecting the ova, the sperm, doing in vitro fertilization, and then taking a small biopsy and look at it. Does it carry the NF1 genetic mutation or not? And if it's not, then you can implant it and proceed with pregnancy. The caveat to that is at least to my knowledge, that insurance do not cover it. Same ways that they do not cover IVF. But there are some community resources, fundraising activities that can help offset some of this cost. The question about MRIs during pregnancy, first of all, regardless NF1, we do not prefer to get MRIs in the first or second trimester. And then if we need to get an MRI in the third trimester, we typically get it without contrast. Just getting MRIs, again, it's back to the question, when do you get it? If there are no symptoms, there are no reason to have an MRI during pregnancy. Even if, the risk is minimal to the fetus, it's not zero. Typically, the pregnant women with NF1 should be followed by high-risk OB doctors. So these are OB doctors that specialize in seeing people with medical conditions. It's more than the bread and butter OB care. They're having the skill set to manage any complications that can come with NF1, or like high blood pressure, for example, or if there's any nerve pain or seizures. And typically NF centers or clinics, they collaborate with high-risk OB, in terms of like having this multidisciplinary care before, during, and after pregnancy. So therapeutic development. Can I put this picture here just to emphasize how therapeutic development take time and a lot of collaboration, and it can be quite costly. We're talking here for one compound to be FDA approved, we're talking about 10,000 chemical compounds being tested in labs and in animals, and then moving through different phases of clinical trials before it get to the market and get to you. Power of collaboration, the story of the Koselga or solumetinib approval really emphasized that between the Congress, the RAINS, the CTABs, the NTABs, the NF Consortium, leaders in the field from genetics, pharmaceuticals, clinician, geneticists, that made this story happen. So that's teamwork. We're fortunate that the NF for the NF Clinical Trial Consortium provide, and UAB is the operation center for that. It controls the data, the clinical trials, the committees, and there are several centers involved in the NF Consortium, and Dr. Metrock will go over this as well. So just briefly, what are clinical trials, just for the interest of time? So clinical trials, research studies that involve people, you get a drug or a device that's not available yet to the public. Clinical trials can come in different phases. It can be an open label, meaning you know what you're getting. There's no randomization, or it can be randomized, as I will mention in a second. You either get the um, standard of care, or the new drug, or you get a sugar pill, or the new drug. It come in different phases. I'll get to this in a second. Clinical trials have a strict inclusion and exclusion criteria to make sure that we abide by the protocol and that we're doing the right thing for you and for future patients. It depends on the tumor type, have you had prior therapy or not, what is the age group. Most, I would say 99% of clinical trials exclude pregnant women because we don't know, if this drug is safe for the fetus or not, and how is the rest of the body function, like the heart functions, the blood counts, all of this. Clinical trial come in different phases. The ones that you will hear about is phase 1, 2, and 3. Phase 1 look at, is this treatment safe? And then phase 2 look at, does this treatment work? And then phase 3 include, that basically giving the drug to bigger group of people. And we compare this versus the standard of care. Is there, and Dr. Metrock will talk about this in like low-grade glioma. We're comparing the solumetinib to the standard of care, like the other chemotherapies that's approved for low-grade glioma, and that's how things get, towards the FDA approval. And most of the clinical trials you will see in NF2 is, I'm sorry, in NF1 is in right now is in phase 2. There are a few in phase 1, but the majority in phase 2. How do you find a clinical trial? You talk with your doctor, and most helpful really website is the clinicaltrials.gov. It's very friendly, user-friendly platform. You just type in the type of the tumor. You can actually filter by geographical location, by age. So it's very helpful. And by law, all clinical trials has to be posted on clinicaltrials.gov, and it's updated quite frequently. So if the trial is like go into a pause for a certain period of time, or completed, or not accruing patients anymore, they will list all of this on the website. You can also use the UAB clinical trial, the NF Consortium website, or the CTFs. They have a very neat platform for all kind of clinical trials that target in different tumors and what is the phase. And it's also very easy to navigate. So MEK inhibitors and plexiform neurofibromas, as the most of you are familiar with. And again, Dr. Metrock will go over these medications in a minute. There are several MEK inhibitors. The one that's approved is the solumetinib. Really, there hasn't been a study that looked at this medication kind of side by side. So we can't say that solumetinib is better than trametinib or better than binimetinib or mirdametinib. The solumetinib trial for adults is ongoing in NCI. Every clinical trial will have this kind of serial number, like NCT, and then this number. If you just put it into Google, it's gonna take you to the clinicaltrial.gov, and that's where you can see a lot of information about participating sites, age group, inclusion criteria, and where they are in terms of the process, like if they have published any data related to that. There are clinical trials in malignant peripheral nerve sheath tumors, collaboration between the SARC, or the Sarcoma Consortium, and the NF Consortium. Majority of those are what we call combinatorial therapies, using two drugs that work differently, trying to attack this tumor from different angles. There is one trial in Mayo Clinic that actually inject a man-made, genetically modified measles virus into the malignant peripheral nerve sheath tumor, and it's a phase 1 study, meaning that they're still looking at the safety. The agents kind of tested in cutaneous neurofibromas, some topical medication, rapamycin, micimoid. I can't pronounce that, but there are topical medications that have been tested. The current trials is solumetinib, the oral solumetinib, that's at UAB and NCI, and that's enroll people that's older than 18. There's also a trial for topical MEK inhibitor, and this is the serial number for it. This trial is in, I believe, 4 or 5 center. It's double-blinded. That means that neither you or your doctor know if you're getting the real drug or if you're getting the placebo. And it's a randomized control trial. So 50% chance of either getting the actual drug or getting the placebo. And both of these trials are ongoing. Some of the challenges that face the clinical trial in cutaneous neurofibromas, these are benign tumors. Yes, they can be problematic in terms of the itching or the psychological impact, but how do you treat them? Like, are you going to commit a patient to this oral drug with some side effects that, again, Dr. Korf will go over them? It's not trivial. And if you do, then for how long? And are you trying to fix one problem and then you create another problem? Like, you're trying to help with the appearance of this cutaneous neurofibromas, but then there is something else, like as a side effect from a drug, that the patient is experiencing. And that's what the field is trying to come up with, of more different treatment approaches and more kind of meaningful, what we call outcome measurement, meaning what really matters. And then, again, the safety, the cost of this drug, and how do you measure drug efficacy, or what we call trial endpoint. How do we treat, NF1 related tumors? If they're not causing problems, then we watch them, because as I mentioned earlier in the presentation, the manifestation can differ with age. Like sometimes you experience growth and this tumor become quiet. So why do you go through surgery or medication if they are not causing problems? Surgery and it can be challenging, because these are not like a hard balls that a surgeon can chill out. Surgery can cause, there's a risk of permanent damage that can happen with them. But it's if the tumor is causing an weakness or disability, and if the surgery is done by experienced surgeon in an NF center, then this risk go much lower. Clinical trials, if eligible, and as I mentioned, there are several ways you can look at clinical trials. And then off-label therapy. So what does off-label therapy mean? Off-label therapy mean it's a use of a drug for unapproved indication or unapproved age group. For example, propranolol. Propranolol, or you may hear about it. It's a drug. It's a blood pressure medication. But we found it worked for an anxiety, it works for tremor. So we can actually give it to people for tremors, while it's not FDA approved for tremors. So it is legal. There are some studies that found that 1 of every 5 prescriptions in the United States are actually off-label. So it's used quite frequently. But we have to have the rationale. Like, for example, solumetinib, it's FDA approved for plexiform neurofibromas. Well, in children up to 18 years old. Well, if I have an adult that's having a problematic plexiform neurofibromas, we can offer them this medication as an off-label indication. Yes, it's approved, but we're trying to use it in a different age group. Approval through insurance or not, that can differ, depend on the insurance plan. But either of these, the pharmaceuticals that make the MEK inhibitors, they have very good patient assistance programs. So you should not delay. Like if you or your physician feels that you will benefit from one of these medications, then there are avenues to obtain it if it's denied from the insurance. In malignant tumors like malignant glioma in the brain or malignant peripheral nerve sheath tumor, we use cytotoxic chemotherapies, and also we use radiation therapy. But we try to keep radiation therapy I wouldn't call it the last card, but we try not to use it unless it's absolutely indicated, because the studies found that people with NF1 may carry a higher risk of developing malignant tumors down the road if they're exposed to radiation. So we have to consider this increased risk when we're trying to build a treatment plan or the multidisciplinary treatment decision with our radiation oncology colleagues and our surgeons. Neurofibromatosis type 2, and I'm sorry I'm going over time. Sorry for that. So Dr. Korf mentioned that neurofibromatosis type 1 is autosomal dominant. It's less common than NF1. It's 1 in 30,000. Average age at diagnosis is 27 years, and if it's diagnosed or if it's symptomatic in the children, then that's mean a more severe phenotype. This MRIs here, I'm just trying to show you you can see this, the one on the left, you can see the brain, you can see the ears, and this is a hearing nerve tumors. That's another horizontal picture. You can see the eyes, the nose, the ears on the sides, and this is the hearing nerve tumor, the white one. These here on the right, these are called meningiomas, which come from the brain covering layers. And up to half of individuals with NF2 can develop meningiomas. There is, and that's very important, there is a lack of correlation between the vestibular schwannoma size or the growth rate and the rate of the hearing loss. So hearing test and the audiology screening is a fundamental part of the care for individuals with NF2. We don't rely just on MRIs, because these MRIs can be sometimes misleading. Diagnostic criteria, Dr. Korf went over that, so for the interest of time, I will skip them. As Dr. Korf mentioned, there are differences between schwannomas and neurofibromas. Like why are we giving them these different names? And we're not trying to confuse you. But the infrastructure of these tumors are different. You see here, neurofibromas are kind of around and mixed with the nerve, with the wire basically, while the schwannomas you see here, it's kind of has a capsule and growing on what we call peripherally on the tumor, and that's important because how do you approach disease surgically? You know, neurofibromas, we can see how they are mixed with normal nerve tissue. Trying to do resection of those, there is a very high risk of injuring the nerve, versus in schwannomas, you can, again, with experienced surgeon, you can basically shield it out. There is a difference in malignant transformation. Neurofibromas, there is a small percentage that it can turn malignant, while schwannomas do not. And as I mentioned, there are different surgical techniques. So in neurofibromatosis type 2, we have schwannomas, which is this type. Neurofibromatosis type 1, it's more of neurofibromas. Treatment of NF2 related tumor. I want to choose this graph here. You see the ear, And you see here's a nerve, the hearing nerve that's basically carries the signal or the sound and transmit it to the brain. And very close to that is the facial nerve. So it's this nerves that come from the brainstem and run to move the muscles of your face. And as this tumor grows, they can hurt the facial nerve. So we see some facial weakness in terms of the smiling, chewing, the closing the eye, and trying to go there to take this out may cause permanent damage in these two nerves. So surgically is not the first choice unless these tumors are growing rapidly or causing a pressure on the brainstem. Other treatment option are radiotherapy. This is just a graph of gamma knife. Now we have newer techniques of delivering a high dose of radiation to precise location, basically kind of burning these tumors without hurting the surrounding tissue. There are off-label, like cytotoxic chemotherapy in case of ependymomas or meningiomas, if they're growing rapidly, cannot be resected. So there are off-label therapy using bevacizumab, and there are clinical trials. So bevacizumab, think about it like it's a tumor-starving drug. Basically, tumors can secrete this substance that allow them to steal the blood from their neighbors, and that's how they grow. Basically, this drug shut down this stealing mechanism, and that's how they starve tumor cells and shrink them. It was studied in clinical trials. They found that there's hearing response, tumor shrinkage. Percentages are somewhat low. We need something that's more effective than that. But we offer it for people that's run into problems related to these hearing nerve tumors. The drug is given as infusion every 3 weeks. And this is not like a big gun cytotoxic chemotherapy. That's more of a targeted therapy. So the whole thing is like, the hair falling or feeling tired or the side effects that come with this big gun cytotoxic drug don't typically happen with bevacizumab. It is FDA approved drug in colon tumor, lung tumor, brain tumors. And taking a drug off label doesn't mean that we don't do the same meticulous monitoring to catch any side effects, making sure that the drug is doing what it's supposed to do. So we still follow, with MRIs, with clinic visit, making sure that everything is going well. Clinical trials, we have through the NF Clinical Trial Consortium using a drug called the crizotinib. Its study is open for accrual. UAB is one of the participating sites, and it's for people with NF2 that's 6 years or older with progressive vestibular schwannomas. The tumor has to be growing, not just there, just to justify being on a drug. It's an oral medication. It's a targeted therapy, so it's not. It's a targeted therapy, so again, it's not like a big gun chemotherapy agent, and it's approved for lung tumors. There are other trials ongoing in NF2. Bergatinib is another oral drug, and it's at Mass General for people older than 12, and solumetinib in Cincinnati for people between 3 and 45. This is a graph of the hearing test, and that's done in our ENT clinic with the ENT doctor and audiologist. Schwannomatosis, as Dr. Korf mentioned, it's kind of a new entity, distinct entity, separate from NF2, and pain is the most common symptoms. You can see here on this picture, all these white color lesions that's present on both hips. Presentation is mainly pain, and we have to rule out NF2. going through this. The treatment for schwannomatosis is multidisciplinary pain management, either with medication or with pain blocks, injections, surgery to take it out if it's safely to do so. There are some reports of using off-label bevacizumab published by our colleagues at Hopkins. So we can offer this drug. And there is a clinical trial using this medication called tenezumab, which is a subcutaneous injection. It's in Mass General for people older than 18. It's a double-blinded and a randomized controlled trial, meaning 50% chance to get either the drug or a placebo. And the drug is, I believe, Pfizer is a pharmaceutical company, and they are testing this in osteoarthritis pain. Basically, it kind of shut off the pain signal before it gets to the spinal cord or the brain. We'll see what the result will tell us about it. You can talk about anything now without mentioning COVID. So I hope we start seeing the light in the end of the tunnel. The question is, am I at higher risk for infection compared to people without NF? The answer is no. We're not aware of immunosuppression related to neurofibromatosis that will put you on a higher risk to catch it. I mean, you still should follow the same precautions in terms of social distancing, mask, washing hands, but NF1 per se does not increase the risk to have COVID-19. Am I at high risk of developing more severe complications? Well, it really depends. If you have a plexiform, if there's a plexiform neurofibromas that's causing breathing issues, or if you have lung problem relating to NF1, or if you are on a chemotherapy to treat NF1 related tumor, then yes, you're at higher risk. If you catch COVID, you may develop more severe illness. How do I access NF care? Telehealth. There's actually a study that was published by Dr. Plotkin, Dr. Korf. It was like a survey that was done among all NF clinics, and seeing the impact of how COVID affected the access to healthcare. Only one clinic before COVID, only one NF clinic before COVID that relied on telehealth, but now all NF clinics use telehealth. You should not delay access to care because of COVID. We do telehealth visit. You reach out to us. Do not put off anything just because of COVID, because we can, we can see you. We can get the appropriate workups that's needed. Shall I get the vaccine? Please do. What is the best vaccine? The best vaccine is the one that you can get. Don't get tangled on all these numbers about efficacy, which vaccine is better. Bottom line, all of these vaccines prevent severe illness if you get COVID. So talk with your doctor. I mean, if you have allergy or other issues related to vaccination, you bring this up to your doctor. But if the opportunity become available to you to get the vaccine, it doesn't matter which one you get. The last is the transition from pediatric to adult care, and I know I went over time. I'm sorry. We know that the transition from pediatric to adult can be an anxiety-provoking, but we're all here for you. The UAB Genetics Clinic, Dr. Korf and Tammy, they see people in, you see people in children's, you see people in Whitaker. We are all part of the same team with our colleagues in children's. There is now a clinic called the STEP Clinic. It's basically the staging transition for every patient. It's getting plugged in with a primary care physician, Dr. Carly Stein. She's actually trained in pediatric and medicine, and she helped kind of bridging these two worlds. She's great. The clinic started last fall. And there is the AYA program, the Adolescents and Young Adults Oncology Program, through the UAB O'Neill Comprehensive Cancer Center. We meet frequently with our colleagues from Children's Hospital. We go over treatment plans for our patients. We share what's new in science. We're all kind of on the same page. So while this can be an anxiety-provoking, we're trying to make it easier on you and your family, and we're all here for you. Dr. Korf mentioned the future direction, kind of basically how do we predict progression, trial endpoints, like what do we really look for? We don't want to be just chasing MRIs to make the lesions look better. We want to get to something that's meaningful to you, helping improve your quality of life, helping minimize any disability or problems that come with these tumors. Trying to incorporate the volumetric MRI analysis that gives a 3D or a better picture of these tumors and incorporate this into standard of care. I think one of the major goals for us is to identify who needs treatment, trying to use more effective or the field through research coming up with more effective therapies. Combinatorial therapies, as I mentioned, like in malignant peripheral nerve sheath tumor, trying to attack the same tumor from different angles. And prevention study, can we use a drug or a device that prevent even problems or before they start happening? And as I discussed, the telehealth and access to care in NF. We hate, the COVID and what it did to our community. But if some good things that came out of that was the improving access to our patients who live several hours from us in different states, and we feel proud that we're available and we will remain available for all of you, no matter where you are. That's your team. That's your team. It takes a village to care for people with NF. Neurofibromatosis, and we're proud to be part of this team. Between genetics, the NF Consortium, surgeons, neuro-oncologists, pathologists, and I'm sorry if I missed some names, but we're all here for you. We're on your side. That's our contact information, and I thank you. I'm sorry for going over time. I know Katie will hate me.
Well, thank you, Dr. Lobbous. I know that was important information. I know we have a lot of adults and loved ones of adults on the call today. It's hard to get everything in, and I think in the time we have today, you did an excellent job. And as many people have commented in the Q&A, it looks like we have an opportunity to do some additional webinars in the future that we can talk about at the end of our webinar today to make sure that we're providing your skill set to the community that's here today. So
I would love to do that. Thank you. Thanks.
We are running over, and for the interest of time, I think what we're going to do is just proceed directly through to Dr. Metrock, who is the pediatric neuro-oncologist at UAB and Children's of Alabama. We will have some time for Q&A at the end that we can run into, but without further ado, why don't I turn it over to Dr. Metrock.
Hi, thank you for having me. Let me try to share my screen. Are you guys seeing that yet?
Mina, you might need to turn your screen off for Dr. Metrock.
Can you share, Katie? Let's see if I can see.
There we go.
Okay. Is mine showing up?
There we go.
All right.
Great.
So I am Katie Metrock. I'm one of our pediatric neuro-oncologists here at UAB and Children's. I am excited to talk to you guys today about what we are doing in pediatrics and some of our clinical trial updates. I do want to disclose that I participated in an advisory board for AstraZeneca regarding treatment of NF1 plexiform neurofibromas. All right, so today the big topics I'm going to cover, I'm going to introduce you to your team here at Children's. For those of you that don't know us, a little bit about special considerations in clinical trials for pediatric patients. I know Dr. Lobbous talked about adult pediatric or about clinical trials in general, but there are some special considerations to think about when kids are involved. I'm going to go into a little bit more detail about plexiform neurofibromas and low-grade gliomas and where we have been with clinical trials and where we are going, with a focus on some future directions at the end, and then just a quick COVID update regarding pediatric patients. All right, so first, your team. We have 4 pediatric neuro-oncologists. So neuro-oncologists are hematology oncology doctors that have a special focus in brain and spinal cord and nerve tumors. Dr. Dahl, who Dr. Korf mentioned, is the deputy director of the NF Clinical Trials Consortium. Dr. Greg Friedman, who works both in the lab and in the clinic, so he's a physician scientist, and Dr. Alva, who heads our genetic predisposition clinic, and then myself. We have 4 advanced practice nurses or nurse practitioners. We have a Hope and Cope team as well, and the focus of that team is that, you know, we are providing care regarding tumors, but we are also providing care for the whole child and family. And so our Hope and Cope team focuses on neuropsychology. Dr. Avi Madden-Swain and Donna Murda are neuropsychologists, and Caroline Davis is a school teacher. She can help families navigate 504 plans, IEPs. We have a social work team with our social worker, Dran Robertson, and our chaplain, Paul Bird. And we have a palliative care team with 2 physicians, Dr. Buckingham and Dr. Johnston, that help us if there's a really clinically complex case with pain management or other issues. And we work very closely with our neurosurgery team, our neuroradiologist, our neuropathologist. She focuses on learning more about the actual tumor tissue. Even though we try to avoid radiation in children, we certainly get the opinions of our radiation oncologists. And then, of course, our genetics team, Dr. Bruce Korf and Tammy Skelton. We are a part of the Children's Oncology Group, which is a national and international group that focuses on phase 2 and phase 3 clinical trials for a variety of cancers, but specifically pediatric. We focus specifically on the pediatric CNS tumors. We are part of the Pediatric Early Phase Clinical Trial Network through COG, which is a phase 1 consortium. And we're one of only a few places around the country that are a part of that network. In addition, we're a part of a couple other consortiums, the PNOC consortium, which is a phase 1 consortium that is dedicated to brain and spinal tumors. So it's the Pacific Neuro-Oncology Consortium. And the focus of that consortium is to find personalized therapy approaches for patients. We're also part of the Sunshine Project Consortium and, of course, the Neurofibromatosis Clinical Trials Consortium. And this is a map of all of the PNOC sites around the world and the NF consortium sites. So we're happy to have those, be a part of those consortiums and give our patients as many opportunities as we can to participate in these trials if they're interested. All right, so clinical trials in pediatrics. There's a few things to think about when we're talking about enrolling a patient in a clinical trial that's a child. So clinical trials themselves can be overwhelming, but when you add a child to the mix, there's the ethical thoughts of, is it right for this particular child when the child may not have the voice, right? The parents are going to be the main voice for that child. And because of that, we have institutional review boards with all clinical trials, but they are very highly scrutinized for pediatric patients to make sure that the trial is something that is as safe as it possibly can be, and that the trial is a meaningful trial, that we're not putting patients on trials that aren't answering very important questions. And because of that, there's a lot of, there can be additional inclusion and exclusion criteria So those are safeguards to ensure the integrity of the trial and ensure the safety of our patients. At the same time, they can be frustrating when, as physicians and parents, we want to get that medicine or that treatment for our patient, but there's something in that trial that excludes them from participating. In addition to the informed consent process, where we are really trying to explain to the family all of the different aspects of the trial, we have to think about if the child wants to participate, and that's called assent. That's the child giving permission to participate in a clinical trial. And so, through the informed consent process, what we talk about is that we're not just enrolling the child on the study, we're also enrolling the whole family, because it takes family members to get the patient back and forth for appointments. There's going to be sometimes extra needle pokes or MRIs or echocardiograms and EKGs. And it's important not to take those for granted, because that might not be right for some patients. So I think it's very important to consider all aspects of that and make sure that the family is fully aware of what the trial involves, and that they feel comfortable committing to that. And at the same time, make sure that the patient understands to their ability whether or not that's something that they want to do as well. Okay, so from there, I'll talk about plexiform neurofibromas and low-grade gliomas. So from our clinic, these are the two main types of tumors that present to us from patients with NF. We certainly have patients with NF2 as well, but much more common in pediatric patients needing attention are the NF1 related plexiform neurofibromas and low-grade gliomas. And that currently is what we have the most clinical trials focused on. Certainly we are participating in the NF2 crizotinib trial that Dr. Lobbous just went over as well, for patients that are 6 years and older. All right, so plexiform neurofibromas. These are present in up to 50% of patients with NF1, and they grow more rapidly in childhood. And I think a lot of patients come to clinic and they say, what exactly is this tumor? And it is, I think the way to think about it is it's a benign tumor, meaning we don't expect that specific tumor to spread elsewhere, and that it's not aggressive or malignant. But it's also hard to sometimes call them benign tumors when we think that they're still causing problems and they require treatment, right? So to the right of the screen here is an illustration of a neurofibroma. And you can see it's a nerve sheath tumor. So you have the nerves running through there, like Dr. Lobbous talked about, and the tumor cells are wrapped around and within that nerve. So it's kind of like thinking of a cable, like with fibers running through it. And that neurofibroma is a tumor that wraps within all of those fibers inside that cable, causing a problem. And a plexiform, sort of a conglomeration of all these neurofibromas running through various nerves, sometimes along the same nerve, and sometimes along different nerves bundled together. And you can see here how that looks on the illustration and then how it looks on the MRI. And this is the same image that Dr. Lobbous had showed you earlier. So how do we treat these? Certainly observation is an option for some patients when the plexiform is not causing significant problems or not growing quickly. Sometimes the best treatment is to watch and avoid side effects from surgeries or medications. In the past, surgery was really one of the only options, but as you can see from this MRI, it would be very difficult to take this out. These tumors are wrapping around nerves. So if you take out a nerve, you lose what other function that nerve was providing. In addition, there can be important blood vessels. Some of these tumors can wrap around important organs. So surgery can be very difficult. And one thing they have found is that if you take out part of a plexiform neurofibroma, often it can grow back. And so patients were undergoing multiple surgeries. And in the case of pediatrics, the question came up over time of, well, is it better to take it out prior to it growing? And that question was very difficult to answer, and I think led some patients to probably getting surgeries that it would be difficult to know if they need it or not. So we have moved over time to trying different medical therapies. Traditional chemotherapies have not been effective in plexiforms. And I included these drugs because some of you may have participated in these trials or heard of them before, but pirfenidone is an antifibrotic agent, and it did not show effect. The tipifarnib drug also failed to show effect. Its ultimate goal with that drug was to try to target this pathway that Dr. Korf mentioned, but it really was not specific enough for that pathway and didn't show effect. Imatinib was a kinase inhibitor type of therapy, and it showed a bit of decrease. 12% of the tumors decreased in volume by 20 to close to 40%, but 12% of patients in a trial was not enough to feel like we were making the ground we needed to make. So we've now moved to targeting these pathways more specifically. And mTOR inhibitors and MEK inhibitors have been drugs that we've focused on for NF-related tumors. So the mTOR pathway is sort of the sister pathway next to where the MEK protein is. And so what you think about is, like Dr. Korf mentioned, in an NF-related tumor, neurofibromin is not here. So in a cell that's functioning appropriately with neurofibromin intact, you have RAS and it's active, and your cell is smart. It knows, okay, it's time to turn off. We'll use neurofibromin and we'll turn the cell off so it doesn't keep growing into a tumor. But when you have NF1 and you don't have the neurofibromin anymore, what happens is RAS stays activated. So the cell keeps dividing, and it keeps dividing because it doesn't have that stop mechanism. So the thought is, okay, if all of these little proteins act like dominoes, and you need one to activate the next one, to activate the next one, if you take out one of those dominoes, then perhaps you can keep the cell from growing. And that's why we used mTOR inhibitors as some of the first drugs to try. And sirolimus and everolimus are two of the main mTOR inhibitors on the market. There was a phase 2 study in patients with plexiforms, and it included patients greater than 3 years of age. It enrolled 61 patients, and they kind of looked at some of the patients. I think 12 or 13 of them had what we call non-progressive plexiforms. So they were causing problems, but they weren't growing. They weren't in active growth states at the time that those patients started. And they found that there really wasn't any benefit. They weren't shrinking. So they said there was no efficacy, no benefit for sirolimus in patients with non-progressive plexiforms. In patients that had plexiforms that were actively growing at the time that they started these medicines, what they found was that they weren't shrinking the tumors, but they stopped them from growing by about 3 to 4 months longer than anything that had been tried before. And then overall, these were well tolerated. And everolimus showed about the same. But again, this wasn't the results that obviously anyone wanted. So along come MEK inhibitors. And these prevent tumor growth by disrupting this part of the pathway. So you wipe out MEK, and then that acts as your stop mechanism where neurofibromin isn't acting the way it should. And the special thing about these is you take them by mouth. So it's not like traditional chemotherapy drugs where they're injected through an IV. Instead, patients can take them at home by mouth. The first MEK inhibitor that was reported was back in the 1990s, and trametinib was the first MEK inhibitor approved by the FDA for treatment of melanoma. Now, other important MEK inhibitors that we'll be talking about are selumetinib, which is the first FDA approved for plexiform neurofibromas, and then also binimetinib and mirdametinib that have been in clinical trials for plexiforms. So the SPRINT trial, this is a now kind of famous trial in the world of NF. It's a phase 2 trial that took place between August of 2015 and August of 2016, and had 50 patients with NF1, and the keys here are inoperable plexiform neurofibromas that were causing problems, that were causing morbidity. Those were the patients that were eligible. Patients between 2 and 18 years of age could take part in the study. They used selumetinib. Everybody got the same dose. And in pediatrics, we dose based on the size of the patient. Meter squared actually is the best way to determine a dose. It's not like in the adult world where it's one set dose for adults. Kids aren't just little adults. We have to think about them a little differently. So they're dosed based on their size. And they take the medicine twice a day by mouth every day. And we call them 28-day cycles because at the end of the cycle is a good time to stop and evaluate and make sure that labs are okay and that there aren't any extra side effects that we need to be thinking about. So in this trial, they saw partial responses, and a partial response means that the tumor shrunk by 20%, which is, when you're thinking about volume, shrinking by 20% can be a very big deal. And they saw partial responses in 35 patients. That's 70% of the patients. And that actually matched with the phase 1 trial that had 24 patients. They had 17 partial responders as well. So 70%. And 28 of those have what we call a durable response, meaning it's lasting more than a year. And additional 12 patients had stabilized disease, which means that the tumor stopped growing or wasn't growing, which can also be helpful. Of course, we always want it to shrink, but sometimes just getting it to stop growing is a big win. So in addition to just seeing tumor shrinkage, patients in the trial, that the kids themselves were reporting improvement in their pain. The children and the parents reported an improvement in their daily functioning because the pain was better. So not only was the pain better, but they were actually able to do more. And they reported an overall health-related quality of life improvement, just feeling that overall they felt better. We saw an improvement in strength in over half the patients and an improvement in range of motion in close to 40% of the patients. Now, there were 5 patients that had to come off the drug because of toxic effects that we'll talk about, and 6 patients that had tumor progression. So 6 patients on this study ultimately ended up having tumors that grew, and we don't know why yet, why some patients are responding so well and others aren't. That's a question we still need to answer. I like this graph because I think it presents pretty clearly. This is from the main article about the SPRINT trial. This blue line is the natural history. And what it shows is that at 3 years on follow-up, 15% of the natural history patients, so if you just follow a patient without any medicine, 15% were what we call progression-free survival, meaning that the tumor wasn't growing or causing problems. Whereas in the selumetinib group, 84% of patients at 3 years had progression-free survival. So it's a huge gap. It's huge for the world of plexiform. So the FDA saw that. They saw what a tremendous drug this was, and they designated selumetinib as a breakthrough therapy in April of 2018. So it got approved because the trial included children. It was approved for patients 3 to 18 years of age with symptomatic or progressive inoperable NF-related plexiforms. And so the brand name, AstraZeneca is the company that makes selumetinib, and their brand name for that is called Koselugo. And here are 2 of the patients that were on the study that you can see their clinical the decrease in size, the clinical improvement from taking the medicine. There are other MEK inhibitors that are coming through the line. None of them are FDA approved yet, which means that in order to get them, you have to be on one of the clinical trials. Binimetinib was in a study, a phase 2 study in children and adults with plexiforms. I have included on as many slides as I can this the clinicaltrials.gov identifier in case people are looking up these trials. include patients greater than a year of age, and is now closed to accrual, meaning that the trial had set forth a amount of patients it needed to be able to tell whether or not the drug was helping, was beneficial, and we've met that number of patients. And so now we're figuring out those results and the data, and hopefully we'll have that information soon, so we'll know how effective binimetinib has been. Mirdametinib is another MEK inhibitor, and it's been in actually now a couple of trials. There was a phase 2 trial through the NF Consortium, enrolled 19 patients and showed a response in 42% of the patients, and then stable disease in 10 out of 19, so about 53% of patients. One patient had progressive disease by the 8th course, by cycle 8. There's another phase 2 study run by the drug company itself, SpringWorks and MedPace, and it is currently recruiting in adult and pediatric arms. And the special thing about this drug is that it does come in a liquid formulation, and so selumetinib doesn't yet. I know the company is working on that, but for now, to take selumetinib, you have to be able to swallow a pill, and so this particular drug does have a liquid formulation for little kids that still don't know how to swallow pills. So side effects. I've put all these together because the side effects mostly are the same between the different drugs, the basic side effects. There is a thought that perhaps some patients will have experienced some side effects more frequently with one drug than another, but we don't have that information to really be able to say that with confidence yet. And so in general, MEK inhibitor side effects include, and this is for more than 20% of the patients that take it, they can have changes in their retina. That's more often seen in the adult side, but we certainly monitor for it in our children as well with frequent eye exams. Rash, and the rash can be pretty significant. And there's different kinds of rash that we can see. Sometimes it's an acne type rash that can be on the face or the back or the chest. It can be all over, but those are the most likely places. And it can be treated with antibiotics, and sometimes that helps, but for some patients, it just doesn't seem to work. Or the rash can be kind of like a sunburn type rash and be very uncomfortable. Often if the rash is bad enough, we will have to stop the drug or interrupt it for periods of time. Sometimes we, like I said, we use antibiotics or we use steroids to treat that rash. There can be swelling and fluid retention. It can happen in the arms, the legs, the face. So we watch for that very closely. An elevation in something called CPK, which is creatinine phosphokinase, and it's an enzyme that can be released by muscles. And usually the kids that have the increase, it really doesn't bother them. They don't notice it. If it bothers them, we do need to address that. But sometimes they can have very high spikes in this, and the worry would be whether or not it affects their kidneys, but it generally does not. They can feel tired or weak or lack energy. There can be changes in hair, and this can be pretty striking. Sometimes the hair can thin, but the thing that can be the most striking is sometimes it can turn bleach blonde, very, very blonde. And some patients it happens very quickly, and in other patients they can be on it for a long time without any changes. Again, we don't quite understand why there's that variation. And then there can be infections around the skin, around the fingernails and toenails. Less likely, so between 10 and 20% of patients can get muscle spasms, muscle pain or weakness, a decrease in the red blood cells. I don't usually see that in my pediatric patients, but we watch for it. Decreased protein in the blood or weight gain. And then between 1 and 10% of patients have described a change in their taste. There have been, again, reports of stomach or intestinal tears. Again, not something we usually see in pediatrics. Blood clots, we watch for changes in heart rhythm. We watch for changes in kidney and liver. We watch for the heart, something called ejection fraction is its ability to pump blood, and sometimes that can start to decrease, and which case we would hold or monitor the hold or decrease the drug dose. Diarrhea, fever, high blood pressure, all of these are things that can happen in these patients. So I say all of that because it's important to think about if patients are going on these drugs, that it is a commitment to take it. The drug for selumetinib is twice a day, every day. For some of the other MEK inhibitors, it's twice a day for 3 weeks with a 1-week break in between. And with selumetinib, you have to take the drug on an empty stomach right now. And so sometimes families really have to sort of shuffle their schedule a little bit, especially with our little kids that can't understand that as well, to try to make sure they're taking the drug the right way and absorbing it the most effectively. And then there can be these the side effects on top of it. So they're wonderful drugs. They've helped us make big strides in the field, but there are things to think about and to make sure it's right for every patient and that patients are tolerating it safely. And then lastly, for plexiform neurofibromas, there's a trial that just recently closed with cabozantinib. And this is a drug that targets blood vessel formation and the cells that help support the tumor. It is for patients 3 years and older, and it just recently closed to accrual. So we're still collecting all the information on the patients that are enrolled and analyzing that data. So there'll be more to come, hopefully soon, about how Cabo has worked for patients. All right, so moving on to low-grade gliomas. What is a low-grade glioma? It is defined by the World Health Organization as any type of grade 1 or 2 glioma. And a grade of a tumor means how aggressive it is. And so grade 1 and 2 tumors are benign or low grade, and a grade 3 or 4 tumor would be a high grade malignant cancerous tumor. So these tumors are considered benign, but again, it's hard to call them benign if they're causing significant problems, and some of them can. For all of pediatrics, not just NF, low-grade gliomas are the most common pediatric brain tumor, and can occur in 2 per 100,000 children a year. For NF patients, NF1 patients have a 15 to 20% likelihood of developing a low-grade glioma. And here are pictures. This is an optic pathway glioma. And so optic pathway means this is like an MRI where you're looking down at the patient. So this is the child's nose and eyes, and then this is the back of the head, and here would be ears. So you're staring straight down. And optic pathway means anywhere in the eye, all the way back here to what's called the chiasm, where the nerves meet. And so you can tell they're supposed to look the same. And you can tell right here that this optic nerve is much thicker, it's bubbled out, and that tumor is stuck kind of all around and in between that optic nerve that runs back. Here's another patient. So optic pathway gliomas are very common, but you can also have low-grade gliomas that aren't in the pathway. And here's one. This one is very discrete, and it could be taken out by surgery, but that would also be, it's a surgical procedure in the brain. So the question is whether or not that's needed. So how do we treat low-grade gliomas in patients that have NF1? Once these gliomas are detected, sometimes the best treatment is actually observation with surveillance MRIs. And what that means is repeating the MRIs every few months. And for some patients, that might mean every 3 months, and for other patients, every 6 months. And if we feel like the tumor is very stable, meaning it's not growing or causing problems, then we could push it out to a year or more. We monitor with frequent vision exams in patients where the tumor has any possibility of affecting vision. Because if there's a change in vision, sometimes that can be one of the biggest reasons to go ahead and treat. And then also endocrine function, because some of these tumors, there's a gland right here at the chiasm that produces hormones that are really important for growing and developing the right way. And so we watch what's called endocrine function. We watch that hormone function to make sure that we're not having problems where either they're they're growing too fast, they're having early puberty, or they're having decreases in hormones that are really important. When tumors require treatment, one question is, are they amenable to surgery? Would surgery be a good option for this child? And so, if you're trying to go in and take this tumor out, you will lose vision to get the whole tumor out. And in doing that, with NF, we can't say whether or not a tumor could potentially develop in the other eye as well. And so that's a very difficult question sometimes, and it's very patient dependent, and sometimes patient and situation and family dependent. In the past, we have used traditional chemotherapy to treat these these tumors. Carboplatin and vincristine are two chemotherapy drugs that we use, as well as vinblastine, and there's some other regimens as well that I didn't mention, but these particular drugs are given through a special IV called a port that that goes into one of the big veins in the chest, because if you gave them into the little veins of the arms, you would mess up those veins for those children. And so we have to give the medications very frequently. So they go through a special port that stays in the child's chest. And these types of medicines require also a big commitment from the family, because patients are coming with carboplatin and vincristine almost every week, and with vinblastine, it's weekly for sometimes up to 72 weeks. And so that's, missing school, that's the drive to the clinic. And they do have side effects. They're not necessarily as intense as some of the chemotherapy agents that people think about, where people are just feeling very, very sick all the time. These drugs are given in kind of low frequent doses because it's a low grade tumor. So it's not rapidly growing. Instead, it's growing slowly. And so if you were to hit it with really hard chemotherapy, you wouldn't really get that many cells that were trying to grow. So instead, you have to hit these low grade tumors that are growing slowly with slow chemotherapy drugs to try to get them to slow down, stop, or hopefully shrink. What we found is that we get pretty good responses with these. For patients with NF, we sometimes can see with that term progression-free survival up into the 60%. But one, that's not good enough, and two, like I said, it's a huge commitment. The child has a port and frequent visits to come and see us. And so there's a big push for better treatments. And our hope is that those are coming through these targeted therapies. And so we're back to thinking about MEK inhibitors and mTOR inhibitors. So binimetinib has been used for low-grade gliomas. There's a phase 2 study of binimetinib with patients with progressive or recurrent low-grade gliomas. And it was run through both PNOC and the NF consortium. This trial had patients on the PNOC side that did not have NF, and it included patients with NF as well. And we don't have the data yet for the patients with NF, but they have released some information about the non-NF patients. And in this study, they call a partial response 50% shrinkage and a minor response 25% shrinkage in the tumor. So out of the 57 patients without NF, we saw a 50% with response. So we had with the 44 patients with preliminary response data, we had 15 that showed a partial response and 7 that had a minor response. And the side effects are very similar to what we were seeing with patients with plexiforms, with CK elevation and rash. There was some patients with some weakness noticed, and one patient that had some inflammation of the colon. So those are all things that we have to keep watching for. I'm very excited to learn more about what happened with the patients in the NF arm. I do have some images courtesy of Dr. Robeson that ran that trial. This is a patient with a low-grade tumor right here, circled in red. So this is baseline, meaning before the patient started treatment. And this is after a month, and after 3 months, and after 6 months, 9 months, and then at a year. And that's a very remarkable response. What about other MEK inhibitors for low-grade gliomas? Well, selumetinib is certainly one that is showing promise. So the Pediatric Brain Tumor Consortium ran a phase 2 study in patients with previously treated low-grade glioma. So these are patients that might have had that carboplatin and vincristine or the vinblastine therapy, and after coming off, their tumors grew. It included patients between 3 and 21 years of age. Again, a partial response is a 50% decrease in tumor size. This trial was open between 2013 and 2015. There's multiple stratum, but the two that have information released are stratum 1, which are patients without NF, and stratum 3, that are patients with NF. In stratum 1, 9 out of 25 patients, that's up here in this graph, 9 out of 25 patients had a response, partial response, and 10 out of 25 patients with NF had a response. So these graphs are called waterfall plots, and this is basically 0 would mean no change at all. So anything going down is good, right? Because that means shrinkage in size of the tumor. And this little dashed line is that partial response cutoff, so 50%. So if a bar reaches that 50%, it means that patient qualified as getting to that 50% decrease in tumor size. But what you see, and I'll highlight down here because these are the patients that had NF, even the ones that weren't getting to the 50% shrinkage showed some response at some point during this trial. And that's very awesome. So now we're looking at a bigger trial with selumetinib, and this is a children's oncology group study. So like I said before, we're part of children's oncology group, so we do have this study open here. It is for NF associated low-grade gliomas. And the best way to compare is the MEK inhibitor, is selumetinib better than what we've been doing in the past, is to put them head to head in this trial. And so patients that qualify for the trial are randomized, meaning we put in the information and a computer tells us which arm of the study they're going to go on. Are they going to get selumetinib or are they going to get carboplatin and vincristine? So that's called a randomized phase 3 study. It includes patients 2 to 20 years of age. And they have to be patients that have never been treated before. So new diagnosis or previously untreated, to see which ones respond better. And that is actively recruiting now. There has also been a look at mTOR inhibition, just like when plexiforms, we've also looked at it in low-grade gliomas. There was another study through the consortium that looked at everolimus, and it had 22 patients, 15 showed a response, 10 remained free of progression with a median follow-up of 33 months. So also some efficacy and a bit more so with low-grade gliomas than we saw in plexiforms. So, and one thought is, well, can we combine these two types of therapy? You know, perhaps by shutting down just one pathway, we're allowing the tumor to grow through the other pathway. If we just shut down MEK, maybe some tumors escape and those cells are still able to survive by using these other proteins. So can we shut both of them down at the same time? And there's a study through the PNOC consortium right now looking at that. The part of that study is patients, in order to qualify, you actually have to get a biopsy of that tissue, which a lot of our NF patients don't require. And so our hope is that maybe we will be able to have a separate arm with just NF patients later that don't require that tissue if things look good on the phase 1 study that's happening right now. And the two drugs that are specifically being used in that one are trametinib and everolimus. All right, so future directions. We just talked about combination therapy. The big thing we'll see is whether or not patients can tolerate that, because you're potentially adding side effects together, right? And that can cause problems. So we need to see if combination therapy is tolerated, and also if it leads to better success than one drug by itself. We're also looking at kind of immunotherapy or immunostimulants. So can we use the patient's own immune system and trigger it to recognize that tumor is bad and go after that tumor with its own immune system? And there's a drug coming through the line right now, poly-ICLC, that helps stimulate the immune system that hopefully will be out in a clinical trial soon. I think part of our future direction is answering a lot of questions that are still lingering. Like, who will respond to treatments? We had, some patients on those trials with plexiforms or with low-grade gliomas aren't responding as well or at all. So what makes their tumor different? I think answering that up front could be really helpful in making sure we're putting the right patients on the right medications. When is the best time to treat? That's a big question, because right now we treat when it's causing a problem or when it's growing. So the other question is, should we be treating before it's a problem? And we just don't know the answers to that yet. How long should we treat? FDA gave approval for selumetinib to treat as long as needed, so there's no stop time. A lot of the trials have a hard stop around 2 years. The good thing is that patients that have come off and then go back on do seem to respond to retreatment with the medications, and that's huge because that's not always the case with traditional chemotherapy. And what are the long-term side effects? And this is all, in the world of medicine, pretty new, and so we're still learning a lot about that. And we're giving these medications to our little kids, right? And their bodies are still growing and still developing. So how does giving them these medications affect them 10, 20, 30 years from now? And then how can we get the most durable response? So it's great to see a tumor shrink, but we want to make sure we can maintain that shrinkage. And those are going to be questions that we can answer with time. I think with our future directions, we need to focus more on advances in NF2 and schwannomatosis. Again, these patients don't often come to my clinic nearly as much as patients with NF1, but there is a need to learn more about them for the kids that are coming. And also, I think we need to focus on a personalized and precise treatments. I know Dr. Korf mentioned that as well, as potentially one day, as we answer some of those questions listed above, hopefully that can lead us down a path where we're not just doing one catch-all type treatment for everybody, knowing what patient fits what treatment or what treatment fits what patient the best. Okay, and lastly, I'm just going to touch on COVID because I think every presentation right now is seeming to touch on COVID, but as far as we know, there doesn't seem to be an increased risk in general to patients with pediatric patients with NF1. Nobody, there's not enough data to say that for sure. Regarding vaccines, so the vaccines that are approved right now are only approved for adults. So I'm getting questions of, well, when can kids be vaccinated? Should they be vaccinated? So Pfizer and Moderna had vaccine trials open for 3 to 18-year-old age group, and those are now closed, meaning they're following those patients right now to learn more about safety and efficacy in that age group of children. There's hope. I don't think anybody has committed to this yet, but there was hope that potentially the vaccines could be open for some kids by the time school starts next year. But things do move slower in pediatrics than in adults because of those extra barriers we talked about earlier of pediatrics being a vulnerable population and making sure we're doing everything to protect our children that we're giving these medicines to. Pfizer is opening a clinical trial right now for patients 2 to 12 years of age, and Moderna is opening, I believe it's 6 to 12 years of age. We are quite hopeful. I've talked with some of our providers in the infectious disease department here at Children's that those are going to be opening here at UAB and Children's. So as soon as they are open, and if we're able to be one of those sites, that information will absolutely be displayed on our website if you're interested in enrolling your patient. I did specifically ask about our NF patients in terms of would they be allowed to participate in the trials? Would there be any exclusions? And they did not seem to think that there would be or should be any reason to exclude NF patients. I also asked if we thought our NF patients would be on any kind of priority list once the vaccines are approved for children. And at the time, because there doesn't seem to be an increased risk, I don't think that there's going to be any priority given just based on the NF1 diagnosis alone. But perhaps if there are other issues that child faces, that might have them take a priority list. But there's a lot of unknowns about that, so I can't speak to that with any kind of confidence. And with that, I'll just summarize what we talked about in this part of the symposium. So again, pediatric clinical trials have a lot of special considerations because we have to protect our kids and make sure we're doing everything that's safe for them and also providing them still with treatment options. And plexiform neurofibromas right now, here at Children's, we have the MEC NF 201 study, which is the mirdametinib study through SpringWorks, open and enrolling. We just finished with our cabozantinib trial, so we're awaiting those the data to mature and results from that study. And of course, Koselugo has FDA approval. With low-grade gliomas, we are currently enrolling in our COG 1831 study, which is the selumetinib versus the carboplatin vincristine study. And we're awaiting results from binimetinib as well. So our future directions, can we combine therapies for a more robust result? Can we use our own immune systems to help target these tumors? We have a lot of unanswered questions that I think can help guide some more therapeutic options. We have a need to make more advances in the NF2 and schwannomatosis realm. I'm hopeful that we can get to a place of personalized, precise treatment and continue to find better and better treatments and ultimately a cure for these kids and these tumors. So thank you so much. I appreciate your time today. All of these trials are only possible with the commitment from all of you, from the families and the patients. We are truly, truly blessed to be a part of your care. Thank you.
Thank you, Dr. Metrock, so much. Very important information. It's a lot of information. Like I said, the same with Dr. Lobbous to do, but I do feel like there's just so much hope in the future, so much research going on, really just in the last 5 to 7 years. So there's a lot of reason to be optimistic. We are going to barrel through in the interest of time at this point. Some of you may be on Eastern time and is well past your lunchtime. I know we have a number of people in Europe, for example, and thank you for joining us no matter what time zone you're in. Just real quick, a lot of the questions that have been in the Q&A, and some of those have been answered by our panelists, if you'd like to take a look at those. But are there any other questions kind of generally for the greater good? I took a couple of notes based on some things that I've heard. I think the main thing is I'm seeing to our panelists a lot of questions about how to predict, what is the rate of low-grade gliomas in the spine? Or I think one of the big questions that comes up is if you're in early childhood or late childhood, what are the chances that you might develop a tumor that wasn't there when they were diagnosed as an early child?
I can start and make a comment about the plexiforms. We think that they're probably mostly congenital. I can't tell you that that's been rigorously proved, and sometimes they can be pretty subtle early on and might not be noticed. I would say that it's really unusual to see a plexiform neurofibroma show up out of the blue on the surface of the body where you can see it. That wasn't there, at least to some extent, albeit maybe small, at a much earlier point in time. So these don't, if you think of the big facial plexiform neurofibromas or the neurofibromas that cause overgrowth of an arm or a leg, those don't just show up completely unexpectedly if there wasn't some sign of it early on. Internally, it's a little tougher to say because we don't routinely look for plexiform neurofibromas, let's say by imaging in somebody who's asymptomatic. And so when we finally maybe do figure out that there's one there, it's a little hard to tell how long it's been there, and whether it actually developed, in adulthood, or whether it was there all along, but just small. So that's a tougher question to answer. Some of the spinal tumors probably do start at a later point in life and can grow, and sometimes they can grow along a nerve like a plexiform, and those probably are not congenital. So, and one of the questions that often comes up is, should everybody have like a baseline whole body MRI just to see how many tumors they have? The answer is, right now, it's not a routine part of care. It's not always so easy to get. It's not proven really what benefit it offers in terms of how you would follow somebody. We don't treat asymptomatic tumors just because they're there, and certainly not surgically, but even with MEK inhibitors, as you've heard, there are side effects, and there's got to be a reason to treat other than the mere presence of the tumor. The big question is whether treatment at an early point in time, say with a MEK inhibitor, would prevent them from growing to some extent at a later point in time. In other words, is there a benefit to early treatment before symptoms occur? And the answer is we don't know. And in fact, there's a clinical trial that's being planned to look at that exact question. So that's something we hope we'll be able to address in the coming years. But for the moment, it is not usually viewed as an appropriate preventative treatment. It's really confined to symptomatic, non-surgically accessible tumors.
Thank you, Dr. Korf. This was somewhat answered by you, Dr. Lobbous, and you, Dr. Metrock, but are MEKs for life? Is there any evidence that if you stop it, if you don't have to stop it, there's no medical reasons to stop it, can you go off of it and maintain that? What is the current evidence of whether or not it is going to be a MEK for life if you are taking a MEK inhibitor or not taking it?
So I'll start with my thoughts on that. I think that it is very patient dependent at this point because we don't have a lot of data to base those recommendations on. I think for the families that want to do a trial off and see what the tumor does, depending if it's plexiform or a low-grade glioma, I think that's certainly reasonable. And again, hopeful that if needed, we could retreat with the drug and still be able to get a response again. And so I don't think it's necessary to be treatment for life, but I do think in some patients where there's maybe airway compromise or some significant problem related to that tumor, then I might be more hesitant to take them off of that drug. And that just has to be an ongoing conversation with the family. I think a question that I continue to have and have talked about with some of my patients is for females and males too, but certainly, females, when they become childbearing age, what will we do with their MEK inhibitor at that point when they're making decisions for starting a family? And so there's a lot of questions still around these medications. And right now, my best answer to that is that it's a very patient by patient question to answer.
I agree with Katie. It's depending really the situation, where the tumor is, rate of growth. My take on that are these medications when they came to the market, especially the earlier one like trametinib or binimetinib. The initial approval was for melanoma. Like these are can be aggressive tumors, so the intention was not really to leave people on this medication long term. I think the more we learn about long-term side effects, as what Katie pointed to, is I think that's what guide like the duration of treatment. I always like to offer to my patients a break from the medication and see what happens, especially if there is no airway compromise or disability related to the tumor. But it's kind of case by case basis. I know Dr. Korf think.
I don't think I have anything to add to that.
There's one question I just want to, I saw it like a minute ago about the spinal cord glioma. I just sent a link for a paper that Dr. Korf, Dr. Metrock, and myself wrote last year about glioma in neurofibromatosis. Spinal cord gliomas are extremely rare, even in people without NF1. The most common location for glioma tend to be the optic pathway, and then the second location is the brain stem, or the back of the brain. We call it the cerebellum. And there are different MRI features that help differentiate if this is just a vacuolization or non-significant finding, or if this is a tumor. The appearance on the MRI is different. So we don't rely just on one picture or one sequences. We look at all the sequences. And by far, when it comes to the spinal cord, by far the neurofibromas, or the nerves that, the tumor that come from the exiting nerves, are more common than internal gliomas. That's in terms of the NF1. NF2, it's different, because NF2, you can develop these meningiomas, schwannomas, ependymomas, and they can happen along the spinal cord. So I hope that answers the question. I don't know what I clicked, but I don't see it right now.
Yes, Dr. Lobbous, for those that need to, in the chat feature, there's a number of links that have been added that are some of the resources that our presenters have had. As well, the Q&A should be visible to everybody in terms of what the questions were and the answers. One more question that has come up is growth and puberty. So taking a step back from the oncology world, maybe this is for you, Dr. Korf. At what age is it concerning if there's been little to no signs of puberty for a girl and or boy?
Yeah, I'm not sure that I have a specific age. There's a range of normal ages for puberty, and it's probably a question better for a pediatric endocrinologist to answer, but there is a normal range in terms of puberty, and you will see sometimes delayed puberty in NF1. I would say, at least in the patients I followed, the more common situation is early onset of puberty, sometimes dramatically early. And when that happens, we tend to worry about optic gliomas. Delayed puberty does occur. Most of the time, it's not obvious why, not clear what the underlying cause is. I don't know if Katie has any thing to add on that, but we would usually refer to an endocrinologist to work that up.
Got to typing on another question. What was the one that you're talking about with?
Oh, the question was, what age, if a girl hasn't gone into puberty, would you be concerned?
Some of that, and I'm not sure, I again apologize, I was really wrapped up in answering this one. But some of that does depend on what the other females in the family have when they experienced their puberty. So sometimes blooming late like that can happen in families, and that can be totally normal for that particular child. But I absolutely think if there's a concern, then I would definitely involve the pediatrician and endocrinologist because there's no harm in looking into that and making sure we're on top of something that could be missed.
Thank you. To our panelists, I know we've answered a lot of the questions in the Q&A chat that people can reference. Are there any questions that you think people may have or common questions that you didn't answer before we close out?
I just want to mention that really knowledge is power. There's a lot of resources out there to help you and help your family know more about what to expect, what to look for, how to engage with other patients, other families. CTF is the great resources. The NF Consortium website and the registry. Just, again, knowledge is power. So we thank you.
Yeah, I'd also put in a plug for the Children's Tumor Foundation. I've worked with them for literally decades. And I think if you want one place where you can look for information that's been carefully reviewed by experts and vetted and is reliable, balanced, and well prepared, that would be the one place that I would send people to unhesitatingly. There's lots of other sources of information, but the Children's Tumor Foundation has really worked hard to provide good, clear, accurate information, and it's the first place I would send somebody.
Which is a great segue. While you all have been answering questions to presenting, I pulled up several websites, so I thought I would just visibly show those to people because I know our audience isn't just in Alabama. So I'm going to share screen for a second so you all can see. It may not be as pretty as a PowerPoint. Let me see if this will show real quick. This is the NF registry video.
People living with neurofibromatosis, or NF, often hear watch and wait and may feel frustrated without a way to actively help fight this disorder. But in fact, an energized, motivated patient community is the only way we are going to find treatments. If you or your child is living with any type of NF, you can help speed up the search for better treatments and perhaps a cure. How can you do this? You can join the NF registry. The NF registry benefits both patients and researchers. Patients use it to see how their symptoms are like and unlike others. They can also find out about potential new treatments, also known as clinical trials. To understand a disease like NF, we need your help. Researchers simply cannot do it alone. This is because the symptoms of NF are different for each individual. For example, one person with NF may have only neurofibromas, while another may have an optic nerve tumor. Others will have both of these manifestations, plus bone problems. With so many possible combinations, a one-size-fits-all treatment is unlikely to exist. We need to look more closely, and this means we need the participation of everyone in the NF community. When we look at the other rare disease communities that have found new treatments, we see one thing they have in common. They built patient registries. The registries led directly to improved treatments and better lives for their patients. It is certain that the NF community can create a similar success story if we work together. To register, go to the nfregistry.org website, enter some basic data, and complete a medical questionnaire. You choose whether or not you wish to be contacted about clinical trials. Even if you don't wish to take part in a clinical trial, adding your experience with NF to the registry makes it a better tool for all. Your information is kept entirely confidential in a secure database that is designed and maintained specifically for rare disease registries. If you want a better life for people with NF, don't just watch and wait. We can do this together. Visit nfregistry.org today and let's help end NF.
The other site I was going to point out, for those of you that are on social media, there is a UAB NF program Facebook page. This is anonymous, so your liking or joining this does not share any information unless you'd like to comment or message, so you can feel very comfortable joining this. But this is where we put a lot of the information and push things out via social media to our folks, regardless of where they are. You'll notice there's been past events. We also share information from Children's Tumor Foundation, who's sponsoring this event today. Really a variety of educational awareness as well as clinical information for you. I shared that Dr. Korf mentioned the Children's Tumor Foundation website, which is really simple, ctf.org. But I specifically pulled up in here the NF registry page so you can learn more about it, the video I just shared. A lot of new information. They've recently redone the site. The NF registry, like the video said, is really, really critically important for a couple of reasons. One, if you are interested in taking part in any trials or studies and you opt in to receive that, you may receive an email notification. For example, if your child struggles with cognitive delay, peer-to-peer social interactions or other information, there may be some studies, there's some interview opportunities that may be of interest to you. And the NF registry will send your information to those researchers and they can contact you if that's something you've opted into. The other thing that I always hear is that when it comes time to have a sponsor for a clinical trial, because NF is still considered a rare disease, we have a ready-made patient directory in the NF register we can hand to those sponsors to say, here's the list of everybody that maybe potentially benefit from your study, please sponsor this. So it really is an advocacy thing too, so we encourage people to join there. The other thing I'll share is that this is the website for the Neurofibromatosis Clinic for UAB, and a lot of these links across the top include the research. If you're interested in making an appointment, the information is there for both our pediatric and adult patients. There's also a link to the clinical trials information, which we can't stress enough. Whether you go to clinicaltrials.org, which is the national, very large one where you can search for symptoms or sites, this information sort of culls down sort of where active trials are happening, as well as all of the information that Dr. Metrock, Dr. Korf, and Dr. Lobbous shared today. The only other thing I would add is that if you are a YouTuber, you can go to Children's Tumor Foundation's YouTube page. There's a variety of information there that may be of interest to you, both educational, past webinars, past NF forums, etc. The only other thing I would add is that we are going to be, this is a recorded webinar, so we will be putting that on that UAB NF program page for you on the web page. If you register today for the webinar, we do have a copy of your email, so we will contact you when that's open. We will also post that on the UAB NF Facebook page to notify people when that information is available. Are there any other questions or comments from our panelists before we adjourn for the day?
Well, my only comment is thanking everybody for attending. This was a record for us in terms of number of participants, and also I think where people are located, far more diverse than what we ever have had before. We'll give this some really careful thought as we look into the future in terms of doing these kinds of events and trying to take advantage of now the kind of ready access to forums like this to be able to spread the word educationally. So thanks to everybody, and really thanks to you for organizing and hosting this.
Thank you, Dr.
And also
Korf.
thanks to Mina and Katie, by the way, for terrific talks.
Thank you. Thank you for the opportunity. And,
Thank you to all of our panelists and to everybody that participated today. Wherever you are, we hope you have a great day. Bye-bye.
Thank you.
Bye.